Good evening, ladies and gentlemen. We are so happy to have you here this evening. May I request everyone to please rise for the prayer song, Tamil Thai Valthu. Thank you, everyone. Please take your seat. It's an immense pleasure to welcome you all this evening for the MRgFUS live case demonstration and CME program. MRgFUS is a man-made wonder which can cure the most disabling disease, namely Parkinson's. As everyone is aware that those affected with Parkinson's will have difficulty in doing their activities like brushing their teeth, to even lift a glass of water. The disability is due to tremor, which go uncontrolled and completely uncurable by medication. We are blessed to have this wondrous equipment which uses non-invasive focused ultrasound technology. Isn't it amazing that this procedure is done without blood and knife? MRgFUS is a leading edge technology and first in Indian subcontinent. Tonight, we'll have a live case demonstration, and I'm sure it will be a heartwarming experience to witness that someone is going to feel free from tremors and feel normal again. May I request our special guest, Professor Mahendra Datta and Professor A.V. Srinivasan on the dais. Thank you, sir. Professor Mahendra Datta is one of the most accomplished neurologists in India. He has been associated with various prestigious colleges and hospitals, and he has an experience in the field of neurology for more than 3 decades. Currently, he is working as a senior director in neuro department in BLK Max Super Speciality Hospital, Delhi. And we have retired Professor A.V. Srinivasan from Chennai. He's the director in the Institute of Neurology, Madras Medical College, Chennai, and ex-president, Indian Academy of Neurology, India. He has more than 30 years of experience in the neurology department. I welcome you both, sir. I welcome Professor Mahendra Datta to give a small introduction about Dr. Shen.
Very good evening. At the outset, I'd like to express my gratitude to the chairman, Royal Care Hospital, Dr. K. Madheswaran. And thank you so much, sir, for again asking me to come here. And last time I was in your hospital, and that was the time of almost installation of the equipment. And I witnessed myself the response. The response was tremendous. I think we need to carry this information in the whole country. The only center to have this unique equipment, very expensive equipment, but very rewarding results, very rewarding results. And there were 3 or 4 patients which were subjected to this, and it was an eye-opener. And I did pass on the information in different groups about this. And we are going to learn more about this, and also wish to thank Dr. Vijayan for this occasion to be back in Coimbatore. It's an honor to invite Dr. Chen. I hope I pronounce okay. Dr. J. Cheng Chen. I have a number of friends in your country and I have been there a few times. Lovely people, very warm people, extraordinary hospitality. Dr. Chen is from China Medical University and Hospital, graduated in medicine from China Medical University and PhD in neurosciences from University of London. He has vast experience in research on Parkinson's disease, for which our equipment is meant. Not only that, MRgFUS, but also in other indications which have been FDA approved. He had experience of this disorder for a long time with Oxford Neurosciences Authority Vice Professor Peter Brown. Dr. Chen has a phenomenal experience in pharmaceuticals for Parkinson's disease. Now there is time we are talking not only pharmaceutical but also talking about radio pharmaceuticals, neural pacemakers, deep brain stimulation treatment, as well as Klippel field anomalies and other neurological ailment. He is a visiting professor at the Department of Clinical Neuroscience, University of Oxford, and a research fellow of National Institute for Medical Research, UK. It's an honor to welcome, very warmly welcome Dr. Chen, and will request you to deliver your talk. Looking forward to listen to you, sir.
Thank you for the kind introduction of the chairman. Can everybody see my slide? I think it's okay. Okay, so I will share my experience in MRgFUS ultrasound in Taiwan. And
yes, sir, we can see it quite well.
Yes, then the sound is okay, right? So this is my hospital. We started our MRgFUS ultrasound since 2018. So I share this case with of you first. This is an essential tremor patient, and this abnormal movement disorder is an involuntary rhythmic shaking of upper extremity. And when the tremor occurs during movement, we call it kinetic tremor. And also, like there is certain postural, we call it postural tremor. And if we near a target, there is tremor, we call it intention tremor. And this kind of tremor usually causes tremendous disability. And this gentleman, he got a very severe tremor. We use clinical rating scale of tremor to rating the severity, and it is 77, which is very severe, and quality of life is not very good, is 60. Also, we can use like a service EMG. We put the EMG recording on agonist and antagonist of the muscle. And we can look at the pulse spectrum of the tremor. And usually essential tremor, the frequency is around 6 to 12. And in this gentleman, he got a nearly like 6 hertz tremor, which means that the tremor like oscillating 6 times a second. We can also use like Fourier transformation to look at the time domain frequency, and this is also around 6 hertz. About the pathophysiology of the essential tremor, actually, it is located in the cerebellocortical network. The degeneration of the dentate nucleus may cause abnormal oscillation during the dentate ruberothalamic cortical tract, and also the connecting with the other side of the brainstem. And for essential tremor treatment, VIM is an ordinary target, both in DBS and also in focused ultrasound treatment. But for this VIM, actually, in the thalamus, it is quite blurry in no matter CT or MRI sequence. So how can we like to help visualize VIM? My colleague in clinical, Christine, use a probabilistic tractography to see the individual node during of the thalamus, and the VIM is this green part. But this is very time consuming. So in our daily like treatment, in my daily treatment, we use like tractography to see the pyramidal tract and also somatosensory tract until we localize the VIM based on these two very important tracts. So with focused ultrasound, with the like 1024 sound wave, they focus on one brain individual, like a pea. The lesion is just like the size of a pea. What is very like exciting is that this kind of novel treatment, it can be very small, very accurate. We can, because it's incisionless, and we can monitor real-time temperature and the real-time location during our treatment. We can see if this target is the accurate target and optimal target for the patient. So after the treatment, we can see a size, this kind of like a 4 to 5 millimeter lesion in DWI is quite similar to the stroke lesion. And in our tractography, we can see that the lesion is just next to the pyramidal tract and the somatosensory tract. The clinical result is very good. This is the left side is untreated part, which is still got tremor, and the right side is the treated part, treated hand. And I want to share the joy of this gentleman with you, because he didn't have, like, he cannot hold a glass of water for like nearly 10 years. And after the treatment, he can immediately like hold the cup and drink the water by himself. Look at the signature before and after the treatment, and also the drawing of the spiral, which is quite amazing. And about the EMG recording we have, actually we also see the amplitude of the power spectrum is like 10 times less. You see here is the power of the like -2, and this power of -3. And also the power, the Fourier time frequency time domain frequency also shows the power is like 10 times less. So we got a very good result after the treatment. And after 1 year follow up, the patient still got a very good effect the previous CRST clinical rating scale for tremor is 77, and after 1 year still got is 43. We got a very good tremor reduction. However, that we look at the quality of life, there is there is improvement, but not so like it's from 60 to 70. That may be because of the other hand, the left side still got tremor. The right side got a very good tremor improvement, but left side untreated hand still got a very severe tremor. We can look at the video recording. The left side still got a very severe tremor, but the right side there is nearly no tremor at all. And you can just imagine that just like the patient with the patient of stroke, they got a one-hand disability, they still got a very impaired quality of life. So we decided to treat the other hand. Again, we use our tractography to mapping and to localize our VIM. And after the treatment, he got both hand tremor reduction. And we look at the rating scale. It's from 77 to 26. And what is most important is quality of life. With one hand treatment, it's from 60 to 70. But with the other hand treatment, it got the quality of life became 90, which is a huge improvement after second hand treatment. So this is the essential tremor, and this is the first bilateral essential tremor treatment in Taiwan. And the FDA just approved the bilateral essential tremor treatment recently. And what next is PD treatment. And after the publish of this paper in JAMA Neurology, the randomized clinical trial, FDA, US FDA also approved that the Parkinson treatment in tremor, and also later that they also have a GPI treatment for Parkinson disease. So there are several targets. US FDA approved the VIM and GPI in Parkinson disease treatment, and there's also one paper talking about substantial nigra treatment published in NEJM. And also there is also some paper about pallidothalamic tract. So this is the connection between thalamus, STN, GPI, and also the connection between thalamus and the GPI is pallidothalamic tract. This network, they are all the treatment target for the Parkinson disease. And how about if we combine several targets, 2 targets at once? Today I'm going to share with you our first dual target MRgFUS focused ultrasound treatment in Parkinson disease. We just published it recently. So this is the pallidothalamic tract in this yellow circle. It's combined with ansa lenticularis and also lenticular fasciculus. And this pallidothalamic tract connected thalamus with globus pallidus. The coordinate of this pallidothalamic tract is the middle of the ACPC line, and also individualized. We put it like 4 to 10 millimeter lateral from the mid ACPC line. And you can see that the lesion of the pallidothalamic tract is over here. And this is our patient with this dual target MRgFUS ultrasound. This is a Parkinson's disease patient with a quite severe action tremor and quite bradykinesia, also with rigidity gait over his right side. The left side is quite okay. After the treatment, you can see the kinetic tremor improved a lot. Also water pouring. The posture tremor also improved a lot. What is also very exciting is the bradykinesia and also rigidity. We can look at the gait later. The improvement also not only on upper limb, but also in lower limb. The gait also improved quite a lot. We are quite excited about this result because the patient actually before he cannot take any medication because of the side effect. So he got a very rigid right limb in bradykinesia, tremor, and also rigidity. So after this dual target treatment, we put the target over polydothymic tract, and also VIM. We to treat both the cardinal feature of the Parkinson's disease. And I think this is the first reported dual target treatment in Parkinson's disease in the world. And this is the 1-year follow-up of the patient. The UPDRS part 3 is significantly reduced, and also in different subscore of the UPDRS score, including like resting tremor, action tremor, also finger tapping, which is for bradykinesia, and also rigidity, got a very, I would say that it's quite satisfying result of this dual target treatment. So my take-home message is that MR-guided focused ultrasound is an incision-less treatment for both essential tremor and Parkinson's disease. And VIM is an effective target for essential tremor. And bilateral VIM in essential tremor further improve the quality of life of the patient. I think it's quite a lot, improved quite a lot. And in our Parkinson's disease, I will say that dual target MR-guided focused ultrasound is a safe and effective treatment for Parkinson's disease. Thank you for the listening, and also thank you for the team in our hospital, and also my collaborator, Professor Mark Edwards, John Rothwell, and Michael Nietzsche, and Masashi and Antonella. And thank you very much.
Yeah. Thank you very much, Professor, for your excellence explicitly expressed for this new process in which the surgical incision and then the blood is not really lost, and you have touched the grace, and it is a class of a person of a classical work to a class of people here, so that we understand better and we will do more things here better. And that too on a very good day today. It's a really Valentine's Day. That's I can call this as a love for science, and that has started by the group, and we are very particularly to the chairman to introduce this particular new procedure in India. We are very grateful to him for bringing this, and particularly Dr. Vijayan and Dr. Arul Selvan has brought this to this the famous city in which I was also born. I take the credit, and in fact, the touch of a class is going to be discussed by the group with this. Then we can just offer our Thank you very much, Professor. Thanks for your excellent talk.
Thank you.
Are we going to have some question answer or? Thank you so much, and sorry keeping you busy on a Valentine Day.
Thank you, Dr. Shen, for enlightening us and sharing your valuable experience with us. I take great privilege and honor to introduce our chairman, Dr. K. Madheshwaran, who is also the neuro and spine surgeon and has an experience in the field of neurosurgery for more than 2 decades. He conceived and completed the 400-bedded Royal Care Super Speciality Hospital in Coimbatore and a successful entrepreneur in this era. I welcome him to give an introduction on MRgFUS. So the stage is yours, sir.
Welcome and good evening, everyone. Respected teachers, neurosurgeons and neurologists. To be honest, I started learning these thalamic, basal ganglia and other things after seeing this equipment. And when we decided to buy I started relearning about those connections, which was very difficult as usual. It is always difficult for neuroscientists to learn these connections. And after going through few things, the understanding is better now. Let us see how this technology and equipment works and how targets are selected. As we know, functional neurosurgery, neurosurgical work to help neurologists and their patients to offer some sort of cure, not control, some sort of cure to these unfortunate patients who suffer from movement disorders. Started in 1940 with various procedures devised with very difficult technology. There was no big technology available those times. So the results were bad. Results came with big complications. So the entire neurosurgical procedures concerned with the movement disorders were looked at differently by referring physicians and patients because the results were bad. Then in 1990, DBS came as an alternative to destructive procedures or ablative procedures, as a stimulative procedures, and results of movement disorder surgeries became little better with DBS, and with the DBS improvement, the results started improving, and patients had tremendous results with DBS, deep brain stimulation. The neurosurgeons offer 3 types of ablative procedures for basal ganglia region or thalamus. Initially it was radio frequency thalamotomy, which is used even now with its risks and complications, and radiosurgery thalamotomies. And now since 2016, MRgFUS thalamotomy has come. FDA has given approval for MRgFUS thalamotomy in 2016. And the procedures carried out with MRgFUS is crossing procedures done with DBS at present. I think last year MRgFUS procedures carried out was around 3,500, which was more than DBS procedures by few hundreds at present. As I said earlier, stimulation procedures, deep brain stimulation came because of the complications associated with the ablative procedures. The advantage of MRgFUS is it is only waves, ultrasound waves, which enters the brain. It is minimally invasive. I don't accept it is non-invasive. because we insert a few pins in the skull. It is minimally invasive. Of course, there is no hardware attached with this technology in the patient who undergoes treatment. There is no hardware at all, which is a great advantage because there is no foreign body inside the patient, unlike in deep brain stimulation, where you place lots of electrodes and a battery in the chest, which create problems. Every one of us might have seen patients with infections and other problems associated with these electrodes placed subcutaneously. Real-time monitoring is available in MRgFUS. It is a fantastic technology, fantastic equipment, and you see everything in the computer monitor. It gives you every information. Where you are going, what is happening, what is the temperature raised at that target, whether you need to move the target 1 millimeter, sub-millimeter, 0.1, 0.2 millimeter movements can be done with the precision because everything is seen in the monitor. Technology is such a super technology, everything is seen. But this technology needs an MRI. Without good MRI support, good MRI technology support, which is available now in most of the places, because the initial localization of the target is done with MRI pictures. We cannot see VAM in MRI pictures. It is a mathematical calculation still, even with the present day MRI. We cannot mark the VAM by images alone. It is a mathematical calculations. And the most important advantage of this MRgFUS is energy is delivered by focusing ultrasound, and the delivered energy creates temperature, raises the temperature at that site. You start the procedure and give ultrasound waves, send ultrasound waves. That sending waves is called sonication. Because people during live demonstration will be talking about sonication. It is nothing, it is just sending ultrasound waves inside the brain, which is called sonication. During sonication, the temperature rises from, it depends on the number of waves, duration of the time which you send waves inside. So the temperature starts rising with each sonication. When you increase the waves which you send inside, you start at low temperature and assess the patient, whether patient is having improvement or whether any complication patient is developing, like numbness or giddiness or something else. Everything can be assessed during sonication and after sonication. Based on that, you can change the target, you can increase the temperature. The most advantages about this is with lower temperature, lesion is not made. And with lower temperature, it is always reversible. When you raise the temperature to above 55, 60 degrees centigrades and keep it for a minute, then permanent lesion is made. That is, you are killing part of brain tissue. Destruction is killing brain tissue. That happens with higher temperature and longer duration. That is done finally after confirmation of target, clinical improvement and other things by patient and by neurologist. After sonication, patient also says, I have improvement, or I am not happy, I don't have improvement, still my tremors is there. Only 20% tremor is controlled. Patient is telling everything. And neurologist examines and confirms, yes, patient is true, only 20% improvement is there. So the target can be moved this way, that way by sub-millimeter precision. I feel MRgFUS is a competitor to deep brain stimulation at present. The most important thing is more and more targets are being found to treat various symptoms of Parkinson's disease. we may not be able to offer any improvement with non-motor symptoms of Parkinson's disease. I think every motor symptom of Parkinson's disease will have some sort of improvement with more and more targets being found and treated because of the improvement in MRI technology. Nowadays, MRIs are available which shows every tract which is passing this way and that way in the brain. At present, the most common target is VAM because that is the most common output nuclei which receives all the information and sends output to the cortex. That is the final common pathway, and that is the easiest nucleus to attack, and that is the nucleus attacked by all these ablative procedures, DBS and now MRgFUS. And now the attempts are being made to create lesions in PPT, pallido-thalamic tract. As we understand, internal pallidum is the common output which sends output to the thalamus. And thalamus receives and sends output through VAM to cortex. So VAM is targeted as a common output nuclei. And nowadays there are attempts being made to create targets in pallidum itself and PTT to relieve all motor symptoms of Parkinson's disease. There are various papers coming out at present. The procedure is carried out by few steps. Under local anesthesia, stereotactic head frame is applied. Patient is shifted to the MRI gantry. Before that, clinical assessment is done 1 week before. CT is done to calculate skull density ratio, which is very important because with very low skull density, ultrasound waves may not be able to enter into the skull. That is very important, SDR. And we are okay with the Indian SDR at present. We have carried out around 16 procedures. We are okay with that. We are not much worried about SDR because our skull SDR is okay for this procedure. It is even good. Then patient is shifted to MRI gantry and preoperative planning CT is merged, MRI is taken again. And generally all movement disorder surgeries are based on ACPC line. Anti-commissure, post-commissure is marked with MRI pictures and a line is drawn. This ACPC line is the base. And the machine itself gives a target, 25% anterior to the PC, 14 mm lateral from that point, lateral to the selected site is the usual machine given targets. And you can select your target. Selecting target is very important. It is not completely complication-free procedures. There are certain things which have to be looked into. Because your lateral margin of the lesion can be touching the internal capsule and create trouble. And if you go little more lateral, you can place half of the lesion in the internal capsule. That has to be kept in mind. It is not completely complication-free procedure. We have to be careful, but technology is excellent. The results are very good for essential tremors and tremor-dominant Parkinson's disease. Our initial experience of 16 cases, we are happy, patients are happy. Few patients had partial relief, of course. As we grow, as we make more attempts to treat other targets, we should have more information. I hope you will understand more about the MRgFUS when it goes on live. I don't want to stand between the live demonstration and you now. Thank you very much for listening.
Thank you, sir, for the brief introduction on the MRgFUS machine. I request Dr. Arulselvan to join with Mr. Raghunandan, who has undergone the procedure. He'll be sharing his experience with us tonight.
Good to see you all. This is the first time in my life. My teacher used to say, you're thick-skulled, so which means you didn't understand anything. This is the first time in our lives where a thick skull is a good thing. Huh? Ladies and gentlemen, I'm so glad to be back. 40 odd years I've had this. Tried everything under the sun. I knew this was the cure. I'd read about it in the net, but I didn't know how to go abroad. I didn't know who the doctor was abroad. And I was scared to go to Taiwan or Tokyo because they may not know my language. I want an English speaking. But then I had come to, there was a doctor in Kunnur. I live in Kunnur in the hills near Ooty. And one doctor said, you go to this hospital and you meet one neuro called Vijayan. I said, one more neuro, one more hospital. I've been through the list. But the first day that we met, we hit it out. He was talking about various things, and as I was leaving, he said, have you heard of, and I completed the sentence. Are you talking about focus ultrasound? St. Mary's in London, they're charging so much. This hospital in New York, he said, no, we have to go to Taiwan. I said, how do I go to Taiwan? I can't travel alone. Both my hands won't work. I have an assistant, I have a cook, I have somebody else, everybody is willing to feed me. But it was getting frustrating. Only if you undergo that will you understand the video our doctor from Taiwan showed. It's about 6 months since I did this. Last month, I decided to make a tomato sandwich for myself. Okay? My staff was not there, whatever. I took a knife and I said, don't cut your fingers. And I sliced the tomato. Sir, why did you not give me Lifetime Achievement Award that day? I applauded myself because these are the small things that matter in life. And tomorrow I'm getting my left hand done. The prognosis is pretty good, according to the doctor from Taiwan, saying quality of life will improve. Last 6 months, this side has been normal, this side hasn't been normal, so I'm tending to drag my feet. I can still drive a car. And when I finished the treatment here, my ambition was, I said, on my way out, I will buy a 350cc motorcycle and drive it home. I didn't do it. Someday I will. Okay, and I will post it to the doctors here who can send it to everybody else. These are small things that you take for granted. I could sign my signature. I haven't been able to do that for I don't know how long. People ask me and I used to say, I'm semi-literate. I can read but I can't write. Is there any tax discount? Please let me know. You have to see the funny side of life. You have to laugh at yourself. And last but not least, I knew there were some eminent visitors from Israel. So I went to Google and tried doing a Google translation. It wouldn't give it to me in English alphabet. I don't know how to read Hebrew. So I WhatsApp a niece in New York and said, do you know anybody who knows Hebrew? These are 2 lines. Can anybody hold the mic for me, please? Or you can play it on this. Neelambur. That one, just a minute. Just hold it on.
שלום, ברוכים הבאים. תודה שבאתם, ותודה רבה על זה שהענקתם לי הזדמנות לחיים חדשים.
Give him a big hand, ladies and gentlemen. All that it said was, hello, thank you for coming, and thank you for giving me a new life. Thank you all. There.
Thank you, sir, for sharing your heartfelt experience and your dream with us. Next, we have the live case demonstration by Dr. V. Arulselvan, neurologist who has been treating vast number of neuro patients affected with epilepsy to movement disorder. He is trained from Walton Center of Neurology, UK, and also he is the first neurologist in Coimbatore to perform deep brain stimulation for Parkinson's disease and temporal lobectomy in intractable epilepsy. He is with us as a consultant neurologist and an active member of MRgFUS team. So the stage is yours, sir.
Thank you. Good evening, everyone. At the outset, I would like to thank respected Chairman Dr. Madheswaran to buy this instrument to play with us. It's very promising. My respected teachers, friends, colleagues. My session is going to be a lot of interrupted because we will be starting the live straight away. And then I'll be giving the in between some videos, lectures, and few slides. So MRgFUS is a magnetic resonant functional guided ultrasound. Movement disorders have been fascinating subspecialty of the neurology, especially after the discovery of the L-DOPA and dopaminergic agonist has changed the way the Parkinson's disease patients experience. Next comes the intervention. The paradigm shift in the treatment movement disorder was the introduction of the deep brain stimulation, but as Dr. Madheswaran said, there are several hinges, anesthesia, fitting the pacemaker, complications associated with this. So generally the movement disorders are classified as hypokinetic and hyperkinetic. We are going to deal with hyperkinetic today, tremor, essential tremor, and tremor predominant Parkinson's disease. Chorea, tics, and myoclonus is all on the way. We just need to find a proper target to treat these disorders. Are we live away? So the patient is getting prepared there, and you can see that the frame is going to be fixed, and the patient will be taken to the MRI suite. We'll see that. Vijayan, sir? Dr. Vijayan?
Hello, the mic. Hello, hello, hello. Sir, am I audible?
So unfortunately, the head needs to be shaven.
Hello.
Hello, Vijayan, are you ready, sir?
Yes, sir. Am I audible?
Yes, you are audible. Can you show our august audiences how you do this fixing?
Yes, sir. Before that, we'll just have one picture of introduction to show that. Yeah. Is the picture on screen, sir?
Yes, sir. It's on screen.
That's not the crew of Apollo 11 traveling to the moon, but we are going over the moon today, and that's our entire team for MRgFUS. The mission director is our chairman, Dr. Madheswaran. Next to him, Dr. Arulselvan, Dr. Raghu, neurosurgeon, Dr. Sendil, radiologist, and then pan to the other side, you have Dr. Sendil, the radiologist again, Dr. Um, Kevin, our proctor from Taiwan. Next to is Dr. Sendil, and we see the legendary Professor K. Srinivasan and our own dear Professor Mahendirata, who were with us initially to kickstart this program, and we have our anesthetist there, Dr. Selvaraj, and finally myself. Now, now today we are going to show you the treatment as and when it is being performed. Now, Dr. Raghu and Dr. Sendil will, we have already given local anesthesia to the scalp. Our anesthetist team here is ready, and Dr. Raghu and Dr. Sendil are now going to fix the frame. And as and when we fix the frame, as soon as we finish fixing the frame, we'll go over back to Dr. Arul Selvan for continuing his lectures, and then we'll come back when we start the treatment as such.
Raghu, before you put the frame, can you just tell us where you place the local anesthesia so that it will be useful where exactly you need to do that?
The local anesthesia, sir, is usually given at 4 points. Yeah, the anesthetist, over to the anesthetist.
Hello, sir. Hello, am I audible?
Yes, you are. Muthu,
Yes.
go ahead.
Yes, sir. We have performed a block called the bilateral scalp block to anesthetize the entire scalp. So for this, we have to block the 5 nerves. The nerves are, first is supratrochlear, then is supraorbital, then is zygomatico-temporal, then you have an auriculotemporal, and you have a greater and lesser occipital. So first thing you have to palpate this is the mid-pupillary axis. You have to look at the pupil, and from the mid-pupillary axis, you just go above and palpate over the brow. You will find a supraorbital notch. Just above the supraorbital notch is your supraorbital nerve. You perform 2 ml of local anesthesia here to anesthetize the supraorbital notch. Then just medially, just above the nasal bridge, laterally or medial to the supraorbital notch is your supratrochlear nerve. Inject 2 cc of local anesthetic in a fan-shaped manner to block the supratrochlear nerve. Next one is your zygomatico-temporal nerve. Zygomatico-temporal nerve is half inch lateral to your lateral canthus. So just palpate your lateral canthus. Through that you move half inch laterally. Here you will have a zygomatico-temporal bone. You can, if you palpate, you can feel the concavity of the zygomatico-temporal bone. Here you inject 3 cc of local anesthetic in a fan-shaped manner. After that, the next block is your auriculotemporal nerve block. Auriculotemporal nerve block is nothing but it is anterior to the tragus. Palpate the tragus. Just anterior to the tragus, you have to palpate the superficial temporal artery. Just you feel the pulse of superficial temporal artery. Just anterior to the superficial temporal artery is your auriculotemporal nerve. You have to perform block above the temporomandibular joint. To identify the temporomandibular joint, you have to ask the patient to open and close the jaw. Just above the temporomandibular joint and anterior to superficial temporal artery, you perform the auriculotemporal nerve block. Then posterior scalp blocks. For performing posterior scalp blocks, you identify the occipital protuberance and mastoid process. You draw an imaginary line from the occipital protuberance to the mastoid process. You divide the imaginary line into medial 1/3 and lateral 1/3. So this is the medial 1/3 and this is the lateral 1/3. So junction of lateral 1/3 and medial 2/3 is your lesser occipital nerve. Lateral 1/3 and medial 2/3. And junction of medial 1/3 and lateral 2/3 is your greater occipital nerve. So here 3 cc of local anesthetic in a fan-shaped manner, 3 cc of local anesthetic in a fan-shaped manner blocks your lesser and greater occipital nerve. Sometimes you receive a small branch of posterior auriculotemporal nerve. For that you have to do a fan-shaped injection behind the pinna. This anesthetic is your posterior cutaneous branch of auriculotemporal nerve. So by doing this bilaterally, you perform the entire scalp block and you have an entire scalp anesthesia. In this concern, it will help in 2 purposes. One is for placing the pins, where you will not able to feel the pain while placing the pin. Second thing is we are circulating a cold saline over the scalp. That will also give an uneasy sensation to the awake patient. That will also numb your sensation of cold saline. This is how we perform the scalp block bilaterally, sir. Thank you.
Thank you. That's wonderful. That's wonderful. Vijayan, can you please answer this question? I mean, why do we need to fix a frame? Why can't we do without any frame?
Yeah, actually this can be done without a frame. The frame is being fixed basically to prevent the head from shaking, because you know that Parkinson's patients can also have head and neck tremors, can have jaw tremors, to prevent, so that we need accurate targeting by the MRI. Even if there is a wee bit of movement, then the target might change. So mainly, though the procedure is frameless, though actually targeting is frameless, but since the MRI is highly sensitive to movement, we need to prevent the head from movement, and hence we need to fix the frame.
That's fine. Basically, we don't want the patients to move their head because they do have a head tremor, chin tremor, jaw tremor. So it needs to be idle and flat on the MRI screen, so that, because the target localization is exactly needs to be there. Otherwise, even a few millimeter errors move the target away, and the desired effect will not be achieved. Is that correct, Vijayan?
Yes, sir, exactly.
Okay. So they are fixing the frame, and once the frame is fixed, the patient will be taken to the MRI, and then already the CT scan will be done, so they will be co-registering. Anand?
What are the pin positions has been placed? Raghu sir, can you explain?
I have fixed 2 in the frontal region and 2 in the occipital region. The frame should be as low as possible, because everyone knows orbitomeatal line. It should coordinate the same line. It's just above the orbitomeatal line. If you fix the screws at this level above, for example, and behind occipital above here, it will not cover the area which we are going to sonicate. So it should be very low as possible. This is the same frame which we use for the DBS. Yeah. So
the frame should be as low as possible, so that we give enough scalp area also for the ultrasound to penetrate, enough ultrasound elements to be active and to penetrate and hit the target.
The most uncomfortable position will be for the patient, because they need to be there for another half an hour to 1 hour with this frame. So that's one of the uncomfortable feeling many of the patients we commented.
Dr. Arul Selvan sir, I request you to carry on with your lecture till we finish this program. Yeah.
Okay, we'll give you a break for 5 minutes and then. So various treatment options are available for the movement disorders. I mean, apart from the drugs, combination of L-dopa and carbidopa, benzoyl dopamine agonist, the duodopa infusion, apomorphine infusion, it's come in as a big way in late 1990s, but unfortunately it's really cumbersome. The apomorphine pump has to be filled every day morning. In UK and other Western countries, it's quite easy, because the patients' attenders are the district nurse who come to the hospital, to come to the home every day morning, and they pick up the syringe and they can go back. So it's not possible in India to come and fill up every day morning with apomorphine pump. Radio frequency lesioning came in a big way, but unfortunately didn't kick off as we expected. As Dr. Madheswaran already said, that the ablative lesions is coming again rather than the functional surgeries. Deep brain stimulation is one of the well-known and well-accepted treatment for the Parkinson's disease and tremor. Thumb and knife surgery, MRgFUS, and of course the last one, gene and therapy. Until now, the deep brain stimulation was the only option we have for the motor fluctuation in the Parkinson's disease and refractory essential tremor. The lesioning surgeries have been there for many years, and in fact, in 1970s, Professor K.S. used to say that the Institute of Neurology at Madras Medical College had several lesioning surgeries with a stereotactic frame. MR-guided focal ultrasound is a new technology. It's an innovative and has the potential to change the way how we teach the movement disorders. Tremors have been long treated with the various medication. Unfortunately, it's not been fruitful and successful as one would expect. The target is the ventro-intermediate nucleus of thalamus. It does wonder the various tremors, especially the essential tremor. However, the technique is fraught with the complication. The motor weakness has been more tremendous, so we need to leave the radio frequency lesioning. It's a novel treatment. The MRgFUS is a novel technique to treat the movement disorders. The US FDA approved in 2016 after the research and regional journal publication in the New England Journal of Medicine for the Parkinson's disease and essential tremor. So US FDA straight away approved in 2016. We know that the ultrasound has been widely used for the diagnostic purposes but monitoring in the medical fields. The focused ultrasound can produce a discrete lesion in the deep parts of the brain also, that is taken as an advantage. The new technique has developed from then. The technique has not been recognized for many years because of the skull being the main barrier. So Grutzmacher, a German physicist, designed a curved quartz plate which could concentrate the ultrasound beam at a specific point. So this revolutionized to introduce this new technique. So we can modulate the intensity of the acoustic energy, frequency, and sonication time on the table depending upon the clinical response. The collated ultrasound targeting the VAM nucleus is sub-millimeter precision and become a very big boon to the patients with essential tremor and tremor predominant Parkinson's disease. First appearance. Right. Okay. Vijayan, are you ready?
Hello? Hello?
Vijayan. Yes.
Yes, sir, we are ready. We're just going to fix the membrane. Just wanted to show you how we are fixing the membrane.
Yeah, this is
Show
the
the
membrane. The water, cool water will be filled inside the membrane. It's quite important so that the head will not be heated up or warmed up. So he's going to explain. Vijayan, please explain.
Yes, sir. Now the surgeons are fitting the membrane around the patient's scalp. The membrane acts as a seal for the cool water that keeps flowing around the scalp. And you can see the membrane being, it's a latex membrane.
See, this membrane alone cost about 5 lakhs. He's stretching the membrane and then it will be placed inside that, just outside the frame, and then water will be filled later on. So the water will be circulating throughout the procedure. Whenever the ultrasound sonication is delivered, so the patient will not feel the warmth. This membrane is disposable. We cannot use it for another patient.
One ring வந்துச்சா கரெக்டாக வந்துருச்சு இதை ஒரு ரிங் இறக்கிடலாம்.
இதை மேலே தூக்கிட்டோம்னா உங்களுக்கு கண்ணு நல்லா
இதை
தெரியும்.
ஒரு ரிங்
இப்போதைக்கு போடும்போது மட்டும் மறைக்கும்.
இதை ஒரு ரிங் இறக்கிடலாம். இழுத்து போடுங்க. ஓகேவா? Okay, sir. Now the membrane is fixed and we are ready to go into the MR console. Sir, you can take over. Once we start the scans, and then when we come back to the sonication, we'll come back live again.
Okay, Vijayan. So actually the procedure, as we talked, we need to fix the frame so that the patient will not move the head.
இதை எடுத்துருவோம்.
Then we'll be taking into the MRI.
மாஸ்கே இப்போ எடுத்துருவோம்.
Silicon membrane will be
முகம் தெரியாது.
fixed. MRgFUS lesioning is performed in a specially designed equipment called Exablate 4000. This is imported from Israel. It consists of multiple arrays with 1024 ultrasonic elements, and all the ultrasonic elements will be focused at one point and then delivered a high frequency energy. CT and MRI brain will be co-registered along with that to plan the target, and the planning and target localization will be done. So we will see how they are doing the target localization. On the table itself, we will assess the tremor, and the tremor vanishes immediately. There is no waiting time at all. On the table, the patient can see that the tremor disappears. And so far, the follow-up is only for 6 hours, 6 to 7 years in the USA, and the tremor relapse rate is less than 5 to 10%. So the tremor lasts longer, the control lasts longer. It's a non-invasive nature. The whole process itself will be completed in 2 to 3 hours. Sorry for the typo. It has been approved for essential tremor and the tremor predominant Parkinson's disease. Raghunandan, our first patient, told about the thick skull. The skull density ratio is very, very important. When you have a thick skull, it's difficult to penetrate with the ultrasound frequency waves. When you have a thin skin, you must easily penetrate so that the desired effect with complications rate will also be higher. So ideally, the skull density ratio, otherwise known as SDR, should be between 0.4 to 0.6. After planning, several subthreshold sonications have been delivered to the target area. The high power sonication is done only with a higher temperature. Whole procedure is done when the patient is awake and conscious so that they can communicate to each other very well. This is a 3 Tesla MRI, can be done only in 3 Tesla. It's a mobile unit table with a helmet-shaped transducer. It's a helmet-shaped focused ultrasound transducer on a mechanical positioning unit. The helmet-shaped do have a 1024 ultrasonic elements. The ultrasound frequency is usually about 620 to 720. The pulses are ranging from 5 to 60 seconds, which are delivered to ablate the target area by multiple sonications. Sonication is nothing but you just give a high frequency ultrasound energy. This hexablate neuro has a complex module, programmable power module that shapes and derives the acoustic beam, and then a water system has been connected along with this, and then it will be stored out. The water cooler system will be outside the MRI unit, and then it sends the cold water. This is a whole MRI board, the positioning system which is in the MRI room. The water system will be a little bit away, and the piezoelectric transducer, and the water will be circulating around the brain in a silicon membrane and a stereotactic head frame to prevent the movement artifact by the patient. This is a sonic elements, so you can see how much is been active. You can see that the target has been localized anterior commissure to posterior commissure. The ACPC line is very, very crucial for any functional movement disorder surgeries, if it is DBS or in the MRgFUS also. So you can see that anterior posterior commissure line. Here AC and then here is a PC. The target is here roughly around 14 to 16 millimeter away from the ACPC line in the lateral. So you need to identify the target and then make sure this is the internal capsule, and the internal capsule bends like this. That's called genu of the internal capsule. That where the pyramidal tract lies. If you increase the lesion may end up into the pyramidal tract, and potentially the patient can have a weakness or paralysis. We don't want this to happen. So that's why we are very careful in calculating the target again and again and doing the subsonication. Before that we decide on the higher sonification or definitive treatment. As you get, the thalamus is very closely knitted with so many nucleus, and this is a target or ventro-intermediate nucleus, is a topographic organization. This is a pyramidal tract. It's only about a few millimeters away from the target. If the heat wave increases, then the patient can have a potential weakness in the limbs and could have an ataxia also. The target is again, this is target, this is internal capsule, this is a sensory nucleus, and this is a third ventricle. Various parameters have been used. We will go through once Vijayan has been ready with the target localization. Right to left, anterior posterior, SI, and then ACPC distance has been calculated, and then we'll fix the target before we go that one. So this is the one subsonication. You can see that heat wave, the ultrasonic wave, and this is the target, and then the temperature is roughly around 45 degrees. So before we decide the temperature, you can see that the temperature will be given for about 20 to 25 seconds, and then it stopped. This is another patient who had a temperature again about 45 degrees. This is the area which has been given. This has been zoomed out, so it looks larger, but when you look at the real time, it's only about few millimeters. There are 4 phases in the treatment. One is the align phase. Check the shape, temperature and location. Verify phase, you give a subsonication, not the desired target. The desired temperature, if you do the lower temperature, just check at see whether the patient have any significant side effects before you go to that we get higher current or higher temperature. Treat low can cause a permanent lesioning, and treat high is also permanent lesioning. So the temperature will be, treat low will be around 50 to 55, treat high is 56, 60. That's depending upon the clinical response and also the skull density ratio. The skull density ratio is very high, then we need a little bit more stronger current to go higher. If they have a low density, then probably the patient get a lesion, but even at a lower temperature. So this will all be dependent on the MRI on the table itself, depending upon the clinical response. This is a patient, you cannot able to draw a circle, and after the treatment he can able to write this. He was attempting to write his name. Unfortunately, he could not do that. Anand, live over. Not it. You can able to write. There's another patient where he cannot able to a spiral drawing. Can able to do that after the procedure. He can able to write the name Nakiran. I'll show you some videos. This is a patient who had a left hand tremor, increased on posture.
Now just spread out your.
He has a leg tremor also, predominantly on the left arm and left leg.
Take a lower here on, hold it, like that. Keep it straight, keep it straight.
This is after the sonication. You could see the tremor is markedly reduced, and you can able to appreciate that.
Till it completely goes off. Till it completely goes off.
This is before the complete sonication. We've done another few sonication for this patient. So the one patient we did the pallidotomy for Parkinson's disease. This is not our patient. The advantage of MRgFUS is several millimeter or sub-millimeter precision. The patient can be on the wake state, alert state. No anesthesia is required except a local anesthesia to fix a frame that will wear away after half an hour. No major complications, real-time improvement. The patient can see the improvement on the table itself. No anesthesia, no incision, almost 90 to 100% effective, no relapse so far. To add these advantages, as I said earlier, the tremor vanishes on the table itself. It's a non-invasive nature. The whole process is completed in 2 to 3 hours. It has been the US FDA and also the Indian the Indian government has approved for essential tremor and tremor predominant Parkinson's disease. This is our first patient who had a history of tremor. This is a scoring system that you can see. This is you, sir, Mr. Raghunandan.
Circle.
He was trying to write. He was trying to do a spirals.
How old do you want?
Circle.
No chance.
When he closes, when he goes close to the paper board, he cannot able to scribble. He was attempting to draw a circle. Is that correct?
That's all I can do.
Circle. Circle portrait.
Sari. They married her.
You could not able to even hold a pencil.
No chance. The line makes some leakage. That's all I can do.
Okay.
Okay, thank you.
Take this.
He was trying to take some pills and then able to swallow. You can see how he swallows the
Hold
pill.
this. And
Not the tablet, sadhan.
illa sadham is also.
He has tremor on both hands, more on the right hand than on the left hand. You're going to have it on the left hand tomorrow.
Usually left means we have more.
Sure. You still have a tremor even now.
Yes, I do.
It is very fun.
Again, target localization. We have 2 or 3 methods the natural, the Atlas States way, and then we have a Kevin's method, who is a Taiwan engineer. Basically, it all lateral, roughly around 14 to 15 millimeter from the ACPC line. It's the ACPC line calculated, and the target has been localized. And then we recheck on the several sagittal, coronal, and axial sections before we finally target. It's a patient who can able to do spirals, our first patient, and he can able to write. So he said in MRgFUS 3 hours, cannot write that at all. Okay. Vijayan, are you ready?
Sir, just a minute, sir.
So they are showing on the screen itself, this is a laptop software. It's been designed by the Exabulate neuro people. Okay, that's fine. It's going to take a few more minutes. You can able to do the spirals. Just taking few more minutes in the target localization. So we'll just continue the lecture. He can able to do the spirals, and after many years, more than 15 to 20 years, can able to write legibly and able to sign a check. This is a patient after the MRgFUS. He cannot able to do that. He can able to write nicely in the Tamil and also in English. Cannot able to drink. He was spilling the water everywhere. And able to hold it, able to drink it without anybody's help. This is another patient who had a tremor predominant Parkinson's disease. His left hand, you could see that action, postural, increased on intention, the tremor.
நல்ல கேள்வி கை நீட்டி மூக்கு தொடுங்க நீட்டுங்க மூக்கு தொடுங்க நீட்டுங்க மூக்கு தொடுங்க ரைட் எப்படி ஃபீல் பண்றீங்க எப்படி ஃபீல் பண்றீங்க ஃபீல் ஐ ஃபீல் வெரி குட் பெயின் மடக்க பெட்டர்ல இல்லைங்க ஃபீல் வெரி குட் ஓகே.
He said, how do you ask?
Hello.
Are you better? He said, not better, but very good. That's all. So tremor is on the next day is tremendously improved. Most managed, he cannot see any tremor. This is another patient.
Tremor காமிச்சிருங்க.
Pre-procedure tremor, you could see that the tremor is very intense. After the procedure, you can able to hold the tremor. Super. The tremor is almost gone now.
Nice.
Live. Jane, can you able to hear me? So they placed the patient in the MRI. This patient had a tremor predominant Parkinson's disease only on the left hand. Right hand is very, very mild.
Vijayan sir,
Yes, hello.
we are all live now.
Yeah, we are live. Show the tremor. Tremor,
Are you going to
tremor.
show the tremor on the...
The patient is on the table now. Patient is on the table and is trying to draw a spiral. You can see the patient on the table. We're very comfortable, and patient is trying to draw a spiral there. You can see the tremor that the patient has. Okay. There he goes. There he goes again, trying to draw another spiral.
Vijayan, can you show us the spiral which he drew?
Yes, sir. We'll be showing it. Once Raghu finishes his task, we'll show it. And we'll also show the tremor now, the enhanced tremor that occurs, especially when the patient is in the console. He's trying to write his name, but
Vijayan, can you tell us the
Yes.
MRgFUS score, the tremor scale?
Yes, sir.
How severe was that? So that then...
Okay, that's the Archimedes spiral which is drawn and trying to write his name. And you can obviously see the tremor. Now this is the before the first sonication. We'll also show you the tremor now. He's holding the rod there. And he had, we had done a Parkinson's disease, unified Parkinson's disease rating scale on him. His rating scale was 44, predominantly motor. All his non-motor symptoms were very, very minimal. Most of these were motor, and it's tremor-dominant Parkinson's disease. It's been unilateral for more than for 7 years now. It's been unilateral for more 7 years. Minimal rigidity, mild to minimal rigidity, and severe tremors. And he's a plumber by occupation. At this point, I would like to thank the sponsors for his treatment. We've had many sponsors for his treatment. One of them is the NGO in Delhi, which is called Sapna, through DSS, and then through their corporate social responsibility, they gave us a fund, and also Coimbatore Rotary East, which has also contributed to this patient for his treatment.
The patient come from Chennai, and we thank our referring consultant, Professor
Vasudevan.
And this moment. Unfortunately, he could not able to afford the treatment, so we generated some funds to help him.
And now the patient will go into the MR console. Sir, over to you, sir, for continuing the lecture. We'll be back after a few moments.
Okay, thanks, Vijayan. So we'll continue the videos. Okay. This is a post-treatment. The tremor is
Super.
They need to bring. Check.
This is after the treatment. You can able to do that easily. Only a mild tremor is there, but as a lesion expands the day by day, and then the tremor will improve continuously, even a mild component will be managed in the rest of the time. This is the same patient. You can able to do that pre-treatment spiral, and then this is after the treatment. You can able to do the spiral clearly. Another patient, spiral within the spiral, not able to do the pre-treatment. After the treatment, he can able to do the drawing himself very well. Another patient, tremor predominant Parkinson's disease. He also had a tremor in the right leg also.
கீழே முதல்ல வச்சுக்கோங்க. ரெஸ்ட் ஸ்டைலில் பார்ப்போம். ரெண்டு தரப்பு பாருங்க. ரெண்டு தரப்பு பாருங்க. இப்போ தூக்கி பிடிக்கிறீங்களா?
The tremor has significantly reduced, as you can see that. The leg tremor also vanished post-meditation. This is a chin tremor, jaw tremor. Another patient, he had essential tremor, as a tremor in the SCA12, strong family history. We're trying to do a spiral, unfortunately, cannot able to do that. Not able to hold the pen to the paper. There's no water in this, but he cannot able to drink it.
बता दीजिए नींद आ रहा है क्या?
After the sonication, you can able to do the spiral now. Super. You can able to write.
Start பண்ணலாம்ல.
Okay, sir. Treatment, sir. Treatment, sir. Treatment, thanks. Treatment. Super, sir. One sonic பண்ணிட்டாங்க சார்.
This patient was referred by Professor.
நம்ம ஸ்டார்ட் பண்ண ட்ரீட்மெண்ட் தாங்க சார்.
Thank you very much. The tremor has disappeared.
Late night here.
Nice.
வருதுங்க சார். Load treatment. இல்லைங்க சார். இல்லைங்க சார். இல்லைங்க சார்.
This is a patient who had a spinocerebellar ataxia type 12, dominated by tremor and ataxia. He was working as CEO in an airspace company. Unfortunately, he could not able to sign for more than 15 years. Can you try to write your name, please, sir? Just give a try. You know that it will be difficult. Write a name. He was trying to write a name. Vijayan, are you here? Are you there? I'm sorry.
Hello, hello. We are here. We've just.
Vijayan, please.
Yeah, the patient is now inside the console. Patient is inside the MRI, and we are starting the treatment. We have loaded the treatment plan, and we first loaded the MRI, which we have done for the patient, which has been fused with the CT scan, and we have loaded it onto the console, MRI console. You can see the console here, and the next thing we are going to do is from the MRI console, the technician is going to prescribe and run the 3D localizer, and she is going to run and 3D localizer. So while she is running the 3D scan, live scan now, which she is going to do, we'll go back to Dr. Arulselvan for the lecture.
Okay, while he is targeting the localizer, I'll show you a few more videos. So he was trying to scribble, he was trying to draw a circle, writing his name, he was attempting to do signature, but whatever he tries, not able to do that at all. Can you try to write your name, please, sir? Just give a try. You know that it will be difficult. Okay, can you sign the check? No, you cannot. Right, okay. Leave it, sir, it's okay. Another video, he was trying to take the water. Sorry, what wrong? Right. अब छोड़ दीजिए माँ वाइंकिंग है माँ spread your fingers please for me. This is after the treatment. The left hand he still has tremor, but we targeted only the right hand down. Left right VAM. Okay. Touch my finger and then touch your nose. Much better, isn't it? He had a voice tremor also. That also improved to about 50%. The hand tremor, writing legibility is all improves to 95 to 100%. You can see that you can write it in the air. Okay, thanks. Can you get a water? Okay. Vijayan, are you able to hear me?
Hello. Hello.
Vijayan, can you able to hear me?
Yeah, I am able to hear you. Sir, okay. Am I audible?
Yes, sir, you are.
Now we're going to locate the transducer. We've loaded the live scan. Finished the live scan, I'm going to locate the transducer. You can see it on the screen. I hope you are able to see it on the screen. It's not.
Transducer local. Yeah, I'm showing them.
Yeah. Scan still running. Okay, the scan is still running. The live MRI is still running, and once it's over, we'll locate the transducer.
Vijayan, can you explain why do we need to locate the transducer?
Yes, sir. It's very important that we locate the transducer. The scan has to identify and locate the transducer so that the MRI now gets integrated with the focus ultrasound, the transducer, ultrasound transducer. Now it is the process is on. You can locate the transducer. You can locate. Yeah. Now we are locating the transducer. Locate Mandingla. It's already done. Okay. And then we'll go to detect MR frequency. We're going to detect an MR frequency shift now. The frequency shift should be anywhere between minus 100 and plus 100. We'll keep it as close as possible to 0.
Vijay, can you also explain what is this green thing to the audience, please?
Excuse me, sir?
What is that green thing?
This one?
The green one. The green one is the CT fused on to the pre-MRI. The CT scan, which was done for the patient, which has been fused to the MRI, so that it's easier for the MRI to locate the target.
Okay. The anatomical target should perfectly match with the MRI film so that we can be error-free.
MRI frequency shift பண்ணியாச்சா?
Scanning.
It's detecting.
Well, it's going to take some time.
Yes, so the frequency shift is minus 136, so we're going to do it again. We're going to scan and detect the frequency shift again, so that it automatically corrects the frequency shift to somewhere near 0, or plus 100 to minus 100. We keep it as close as possible to 0.
Yeah. So you said it needs to be less than 100, is that correct?
Yes, sir. Plus 100 to minus 100, but we
Yes.
keep it as close as possible to 0. It's scanning again to detect the frequency shift, and it will take about 6-7 seconds. Yeah, we've got a frequency shift of 9. Can you see it on the screen, sir?
Yes, you can see 9.
Yeah, that's as close as possible to 0. So we are satisfied with this. And then we're going to go to scan the prepared series now. That's the next step in the process.
So the CT and MRI co-registration being successfully done, the chance of error is going to be really very, very minimal. We will fix the anatomical targets like this and then see that MRI is co-registered with the CT film. We know that the CT film is very good for bone windows and MRI is good for the soft tissue and also the brain windows.
Focus பண்ணலாம். You see that the MR technician is now preparing the scan, one more live scan, and this scan will be fused on to the previous scan which he had done yesterday, during the planning session.
So we do have various protocols, but one we designed is a 3D Fiesta.
Yes, sir. The live scan is a 3D Fiesta, T2 3D Fiesta. The pre-scan which we do is the Bravo null image, white matter null image, where we get a very good delineation of the white and the gray matter.
That's correct, yeah. Now
the machine takes over the MRI console also. Now from now on, all the orders will go from the machine, from the software of the Insightec machine for Exablade Neuro to the MRI console. Further, we'll involve the MRI machine only during the intra-procedural scan to see whether we've made the lesion. As of now, the machine takes over. Most of it is artificial intelligence guided with precision to sub-millimeter level.
We already talked that in the thalamus there are many nucleus are clustered together very few millimeters away. So we are not have a opportunity to miss even do an error of millimeter because it lands into the other area, which we don't want that.
We've had a lot of cases where we have done the SDR. Raghu, can you please tell us what was the SDR commonly the SDR?
For our patients, I think that we had minimum 0.38, maximum it was 0.69. So.
Maximum 0.69.
Yes, sir.
So the ideal one will be between 0.4 to 0.6.
And 50% of our cases was 0.5 around.
Yeah, somewhere around 0.5.
So, yes,
what we've noticed is when we were trying to procure the machine, when Japan and in Taiwan, the SDRs were very low. They were finding it very hard. They were using very high energy levels. And so we were actually a little apprehensive about our own SDR. Then when we started doing the initial cases, when we started doing the SDRs for the initial, we found that our SDRs are quite good, very well in the treatment range. The FDA recommendation is 0.45 plus or minus 0.5, but our SDRs have always been 0.5, most of the time have been 0.5 and above, be it from Jaipur, be it from Delhi, be it from Haryana or Kolkata or Mumbai, Bangalore, Chennai or down south, Madurai, all our SDRs have been, say, we are talking about a Hindustani SDR. Most of our SDRs are very much appropriate for treatment.
Can you tell us the eastern area, like Japan, Taiwan, what will be the usual SDR?
In Japan and Taiwan, usually they struggle. The SDR is less than 0.4, sometimes even less than 0.35. The least accepted SDR is 0.35. Sometimes they've done it at 0.3 also. Now they are trying various methods to increase the SDR above 0.35. One of them was to give bisphosphonates, but that was not been properly replicated in other centers. 4 to 6 months of bisphosphonates and you can increase the SDR to above 0.35 and then make the patient suitable for treatment. In our patient today, we have an SDR of about 38 in the planning stage, 0.38 in the planning stage. So it's a suitable SDR, but still we'll need a little higher energies in this patient rather than the lower energies which we used in the previous patients.
Vijay, can you tell us what's going to happen if they have a low SDR, or what will happen if they have a high SDR? How does it going to imply?
Okay, the ideal SDR is somewhere around 0.45 to 0.55. Now, if they have a very high SDRs, now we'll start off with very low energies. Say for example, if the SDR is about 0.6, 0.7, we start off with very low energies, say like example 1500 joules. And at the end of the treatment, maybe we'll end up even finishing the whole process within 6000 joules, maximum 9000 joules. But if the SDRs are very low, as for example in this case, we might start off with higher joules, like for example 5000, 4500 joules to start with, and we may even end up with somewhere around 40,000 joules. The maximum I think we've used is 48,000, isn't it, Raghu?
Yes, sir.
We used 48,000 joules for a particular patient. So it all again depends upon the patient, whether the patient tolerates it. We increase the power sometimes, but we don't go beyond, usually we don't exceed 900 watts. And
but Vijay is saying about the joules is the delivering of the current strength. So if a higher current has been delivered, higher energy has been delivered, there is going to be a higher chance of lesioning, and then side effects is going to be a little bit higher. Is that correct, Vijay?
Yes, sir. We very careful. We monitor the temperature spread also. We have a live MR thermography which monitors the temperature at various pixels, all or voxels, throughout the MRI in the patient, and it's a live monitoring, and hence it's a live monitoring. We'll know, and we've also marked out the pyramidal tract, and we'll know whether the temperature increases in the pyramidal tract beyond a particular level. Usually, we accept anything that is less than 50.
Okay, now the scan is complete.
Yes.
We're going to plan the target now.
MRI is now doing movement detection scan, sir.
Okay.
It's on the process of doing the automatic movement detection scan, so that then it gives us the targets from which we'll have to change the transducer targets. We'll show that live now.
Updated, sir.
Updated.
Now we can go for reformat. Yeah.
Approve image. Reformat. Let's come to this. We are now reformatting
in all three planes.
The 3D Fiesta in all the three frames. Yes. We've done, and we've in all the three sections, the sagittal, the coronal, and the axial. Since it's an intra-operative or intra-procedural, you won't get much clarity images, but we don't have to worry about the live MRI, because we've already done a planning MRI, pre-planning MRI, and that is going to be fused soon with this live MRI image. And so whatever targets we have fixed will be easily translocated back to this live MRI, and we need not worry about the resolution in the live MRI, because we have the membrane. We have the membrane around, we have water circulating around. You can see the water is cooled to 18 degrees. You see the dissolved oxygen is 1.07. All very good parameters, and hence we need not worry about the resolution in the 3D Fiesta images at present.
Okay, the water temperature is 18 degree. The water is cooling around here, is going, it's not stagnant, it's circulating along this circle. So that during sonification it won't get warmth or heated. So we want to see the target in all the three sections, axial and sagittal and coronal, to make sure that the target has been, desired target has been there in all three sections, so to avoid any errors or mismanagements.
Contrast.
Miscalculations.
Contrast. Central button. What we are actually going to do now, since it's reformatted, now we're going to mark the AC and PC. First we'll mark it in the sagittal plane, which is a very easy plane to mark the AC and the PC, the anterior commissure and the posterior commissure.
The AC-PC line, the anterior commissure and the posterior commissure line is very, very crucial in deciding the targets. Measuring the target.
Yeah. AC, PC. Now you can see on the screens, transducer remove பண்ணிருங்க, overlays எடுத்துருங்க.
Overlays எடுத்துங்க. இதுதான் handler.
Go back. Move the transducer.
Okay.
Remove the transducers.
Overlays. This one.
Transducer. Yeah. Now you can see the AC and PC on the screen. Are you able to appreciate, sir, from there?
Yeah, I'm showing them.
And that's the AC, and this is the posterior commissure. Now Raghu is marking the anterior commissure. He's trying to get the best view so that, yeah. And now he marks
This will be the best.
No, one more. Yeah, that's
This
this.
also.
Now we can see the AC. One more.
This one will be best.
PC, yeah, you can mark that.
Zoom and weld.
You see the zoomed picture of the AC from the center of the posterior border of the AC, and he is now marking the anterior
PC.
border of the PC in the midline. The AC PC marked.
And we
Now
can
we'll go on to midline in the coronal. The coronal section is seen now. And Raghu is now marking the midline. So we need to mark these three parameters first before we start performing the sonication. Okay, the midline is also marked. Now we'll have to adjust the midline so that it exactly bisects the third ventricle. Go back to the overlays. Shall we remove the overlays?
Yes, sir.
Overlays. Yeah. We removed the overlays. The midline is seen. Now, we keep moving until we see that the midline exactly bisects the third ventricle. Okay. Catch hold of the PC and move it. Okay.
So you mark the midline, you mark the ACPC.
Yes, sir. And we are now trying to keep the midline as good as possible in the center so that it bisects the third ventricle. Exactly. I think you'll have to move the AC also a little bit. Little bit. It's a very important step that we mark the midline exactly, because all our measurements are going to be from the midline. No, yeah.
We'll check, sir.
Yeah.
Little bit.
Little more. Yeah, I think that's okay.
Yes.
Come to
AC konjam
come to the tectum. Tectum.
AC konjam.
Tectum going. Now, one trick here is to exactly bisect the tectum. If we bisect the tectum, and now you can see after the adjustments, we've got the ACPC at 25.75, and our initial planning was 25.8 millimeters, the ACPC length. The whole talk will be revolving around ACPC and this midline. Raghu is trying to further perfect the marking of the midline.
Okay,
and we'll now reform it. Raghu will reform it. We are going to reform it so that the markers come in all the three sections, sagittal, and so that the AC and the PC fall in the same plane. Zoom. Zoom. Okay, axial. Tectum. No. Are you bisecting? Tectum.
Yes,
tectum.
sir.
Tectum. Tectum.
Yes, sir.
Tectum. Tectum.
One
Little
more.
more. Little more. Little more. Okay, I think, shall we move the PC a little this side?
1 mm. Sir.
Yeah, a little. We're trying to perfect the midline marking now. But every millimeter is going to matter here.
Yes, sir.
Yeah, you see the tectum is perfectly bisected there.
Midbrain.
Third ventricle.
Yes. Bisected perfectly. Third ventricle. In the midline.
Third ventricle. Wait, hold. Zoom. I hope you are seeing it clearly on the screen. The third ventricle perfectly bisected.
Yes, we did.
Are you in agreement, sir?
Yes, Vijay, we are saying it's exactly bifurcating the
Are we in agreement, the
Yes,
whole
sir.
team? Okay, the whole team is in agreement that the third ventricle is perfectly bisected. Now, the ACPC are exactly placed. Can we move this a little down? Leave it at that.
So we are highlighting the marking is very, very important because it's very crucial.
We'll
Again,
leave it at that.
few millimeters errors makes a big difference. So we are not allowing this
Okay,
to
then
happen.
actual
okay,
we keep doing it again and again. Once anytime we keep changing the markers, we keep doing it again and again. Okay, now we are satisfied with AC, PC and midline. We'll reform it again.
We have done, sir.
We'll reform it again. Switch on the reformat. Yeah, we reformat it again.
We'll mark
And
the
then we'll
default
go
for
for the MR registration.
automatic.
Yes. We're going for the MR registration now since we've marked the AC, PC and midline. We're going for the, and it's going to be automatically done. It will be automatically done by the machine. We wait for about 1.5 to 2 minutes. You can see on the screen that it's trying to fuse the pre-planning MRI with the live MRI, which we have done now.
Why this is done? Jian, can you please explain us?
The MRI, the pre-planning MRI is now being fused to the live MRI. So that once we mark the ACPC midline, the pre-planned MRI is now being fused, which has already been fused to the CT, is now being superimposed on the live MRI, so that whatever targets we had measured on the planning stage will impose these targets now there. You can see the pink line that is coming there, the pink line, that is the internal capsule which we have marked. And
We
that is
made
a
the targets already the last planning session itself. So that's we've been fused with the new MRI, which we acquired lively.
One minute.
Jian, can you show us the target in this?
Target, sir, once the it's the fusion is on, so the automatic registration is being done. So it takes time. We cannot interact with the MRI when the automatic registration is being done. Once it is done, then I'll show you the targets.
Okay. Okay, we will wait.
Once it is done, we will keep verifying this again and again in all the three planes.
The water is again cooling to 15 degree. If the water, after the sonication, if the water is hot, then the sonication will not be given. It has to go back to the cooling mode again. Once the temperature reaches to decide 15 to 18 degrees, then only the sonication could be given.
Zoom. Okay. Now we are checking the registration. The automatic registration has been done. We are checking whether the registration is complete or not. You can see it on your screen as Raghu is moving the images to check whether the automatic registration is complete or not. We'll try to achieve maximum registration here so that the notches and the bony CT, the outline which you can see, is registered.
We'll be checking in all.
Yeah, we have finished the axial. We are checking in the coronal now. It's another most important step in this process, that once the registration is not proper, then your targets may go totally different. So every millimeter being important, the registration has to be very proper here.
Seems to be perfect.
Once when the whole team agrees that the registration is proper, then only we'll proceed to the next stage. Next stage will be the defining the target, but before that, let us see in all the planes. I think it's coming up on your screen now. The sagittal plane is being checked.
Yes, we could see that, yeah.
Seems to be okay, sir.
Raghu is satisfied. Sir, are you satisfied?
Yes, sir. Yes, sir.
Are you satisfied with the registration?
Yes, we did.
If the automatic registration is not okay, then we can go on to the manual registration also. Dr. Kevin, are you okay with the registration? Yeah. We are okay with the registration. The whole team is satisfied with the registration. And the next we go on to define the targets. Back to actual.
The whole process is teamwork. The individual case assessment done by the neurologist
Shall we remove the
independently, and then calculate calculate the UPDR scales, and then the tremor score. Then patients can be explained, consented in every stage process, and finally the team will be done on that day of the procedure. So each component of the team is very, very important. Not only the clinician, the radiologist, the technician, and also the neurosurgeons.
Now you can see the targets which we had already planned, which is being fused on to the live MRI. So we had 4 targets defined in him.
So did you say 4 targets?
Yes, sir, 4 targets. We can see 3 targets which are close to each other and 1 target which is very close to the internal capsule. We're going to avoid this in him. The homunculus lies with the head medially and the leg laterally and the arm in between. So if the leg tremor is prominent, we may try to go lateral, or if we are not satisfied, we may try to go lateral. These 3 targets have been identified by 3 different techniques. And we're going to focus on this target now. This target we're going to focus. We're going to hit it first because not very lateral. At the same time, it's not very. Now we are still in the ACPC plane. Raghu would be moving this target now slightly above, superiorly, 2 millimeters superior to the ACPC plane. Now we'll have to enter the target.
We are going to avoid this target because that's very closer to the internal capsule. We're going to concentrate on the rest of the 3.
Enter.
Out of the 3, we will be choosing 1.
Raghu.
And then we'll see on the table whether the patient has got any improvement. If there is no improvement, probably we'll come back again, choosing another target within a few millimeters away.
13.7, 6.7. So, oh no. Raghu, plus 13.7. Right is the treatment, not minus. So we are 13.7 millimeters from the midline, and we are 6.7 millimeters from the posterior commissure, and in the superior inferior direction we are going to go 2 millimeter above. Yeah, we're going to use 0 first. Go to axial, and then you can see the target now at this level. So we are satisfied with that. We can put a fiducial on that now.
Okay, sir.
No.
13.7, 6.7. Okay.
And we're going to move it 2 millimeter above.
So
you can see that this 2 millimeter above, zoom out, and you can see that's the boundary of the internal capsule, and this is the probable location of the VIM. We have 13.7 millimeter from the midline, 2 millimeter above the ACPC plane, and it is 6.7 millimeter from the posterior commissure. Zoom in, zoom out, axial. Next. Okay. I can't see the ACPC. Okay.
ACPC. 2 mm.
Okay. We are 2 mm above the ACPC plane, and we're going to check the transducer location. Now, can you focus on this, please? The transducer to target, we need to keep all these values about less than a millimeter. Right, it is 4.7. plus 4.57. Anterior it's 8.9 and inferior is 0.5. The superior inferior is finally it's done well. It's 0.5 millimeter, the difference between the transducer previously and now new transducer location. Now we'll have to move the transducer manually. We'll have to go inside and move the transducer manually. To the right, we're going to move 5 to the right and 9 anteriorly. The inferior, we're going to inferior at location of the transducer, we are not going to move because it's 0.5 millimeters. So the patient will be taken out of the, I think you can focus the patient. Patient focus.
Patient focus.
You can see that they are taking the patient out. And they are going to relocate the transducer. You can see that the patient is out. And you can see that they are going to relocate the transducer manually based on the changed new parameters. Based on the new parameters. Right is 5. Somebody can tell Sabari. Sabari, you're there.
So you're making adjustments on here on the head control.
Sabari, right plus 5.
To make the finer
Right on the
adjustments.
plus 5. And anterior is plus 9. அவ்வளோதான். இன்ஃபீரியர் மாற்றாதீங்க.
Unfortunately, the mic cannot go into the MRI console, so they could not really speak what measurement they are doing. So he's showing us the left leg tremor and the left hand tremor. So these machines have been
Okay.
fixed.
Lights on. Lights. We've actually manually moved the transducer as prescribed by the MRI.
Relocate.
உள்ள போனோம்.
They'll finish.
Once the patient is homed in back to the inside the MRI tunnel bore, we'll again try to locate the transducer and see if there are differences and see if we have corrected the locations also.
Okay. Okay, sir. We'll do, sir.
வெளியில வந்துட்டு.
Yes.
Okay.
We'll do, sir.
Locate transducer. Raghu is again locating the transducer, then the MRI again has to start scanning to locate the transducer to the newer position so that we'll see the difference between the previous and the live MRI.
Okay, sir.
Yeah, somebody can focus on the screen.
Yeah.
Sir, are we seeing the screen? Sir, Dr. Arul Selvan, are we seeing the screen?
Yes, we are seeing this.
Now you can see the differences here. The right is 0.7 millimeter, anteroposterior it's 0.8 millimeter, and inferior it's 0.1 millimeter. So it's perfectly aligned. If it is less than 1 millimeter, we'll accept this. It's perfectly aligned. And now we're going to mark the movement detection fiducials. Though this step is slightly superficial, we can still mark the movement detection fiducials so that it helps us to be more careful so that we don't see any movement detection fiducials. We'll have to go to axial, and this is the live MRI you're seeing, and it's all smudged because of water circulating around it and the membrane folds. Raghu is now marking the movement detection fiducials. The fiducials are marked at the places where we get the maximum contrast. At the places where we get the maximum contrast between the CSF and the parenchyma. Now it's being marked in all the three planes, sagittal, coronal and axial. Now sagittal. Put one on the gyrus.
Yeah.
No, three. You have not marked here.
Sir, Anand here.
Yes.
Vijayan sir, for a few minutes, shall we take a break from the theatre for a few minutes?
Yeah, you can. You
From your
can.
room? Probably we'll just show a few more videos of the patients here.
Yeah. Please go ahead.
And we'll come back to you, sir.
Yeah,
Thank
yeah,
you.
yeah.
So let them calculate, and then once they go to the clinical sessions, we'll go back and join with them, and then we'll show the video, and then we'll ask the audience opinion. What do they think about their technology? Is it satisfying?
For someone who was finding it
This is a patient earlier we have done that SCAR 12.
Can I let them do?
Sorry, right. अब छोड़ दीजिए माँ दवाएं किंगे माँ spread your fingers please for me. Okay, keep the left hand down. So he has a bilateral tremor, right, but more on the right side, and the right side treatment was done. Touch my finger and then touch your nose. See the tremor has improved. Much better, isn't it? Okay, are you able to write here? You can see that you can write it in the air. Okay, thanks.
Can get a water. That's excellent. That's really inspiring. How long after you were drinking on your own cup?
I don't know, I've forgotten all these things. Maybe the last 5 years, I'm not able to drink or not able to write or lots of activities. I will have to learn them again.
Right.
For someone who was finding it difficult
The
to
patient's
write,
wife commenting.
look at the precise coloring which he's doing. Doesn't this look beautiful? It took him some time to start getting used to the small tip of the pencil, and he does get tired after coloring a little, but the precision is very much there.
Before we conclude, and then can I ask my respected teachers to have a view? What do they think about this MRgFUS? Mike Anand? Hand mic, please. Hand mic. Ging. Sir, here. Yes, please, sir. Thank you. I'm sorry, they shattered?
Yeah, shattered one.
Yes.
Now, in campus VIM,
Yes.
it's about ACPC and then 6.9 millimeters
Anterior.
and then about some 13.6 or
13.6 to 14 lateral.
Is it the same measurement which we have taken from Sheldon Brown, or is something different?
No, we use the atlas. Apart from the atlas, we also have an American way of calculation, Taiwan way of calculation. So we're calculating at least, that's why there are 3 or 4 target, you could see that. One target the atlas showed very close to the internal capsule. So we just wanted to avoid that one. We choose the rest of 3 and then choose first one to see the clinical response. It is better we'll stick on to that one. But not better, then probably we move 2 millimeter superior or inferior and then see the response. That's the beauty of it, because we can see the response on the table itself.
Yeah.
And if you move more laterally, if it comes to the internal capsule, obviously the patient has got a weakness. Finger grip will be weak, they'll be clumsy, not able to do that. So we can see the weakness also on that one.
Yeah, that's what I like it, because what excited me was the measurement, ACPC.
Yes.
I remember in those days we used to put the pneumocephalogram and then calculate the ACPC, the same millimeters, but with a different X-ray technology. But in the recent one, the way it has been now shown is so accurate. And the other thing is the image fusion. Now, after the scan is done, MRI is done, and again the planned one, that means that you are doing the plan prior to the surgery.
Exactly. Usually we do on the day before to that, after finishing the outpatients, relax and then do the planning.
So that's anatomical planning.
Yes.
Not a physiological planning. Physiological planning is going to come now.
Now, yes.
That's nice. I think AVS sir has to talk about it, because you will be knowing more about it during your days. ACPC line calculation, and I remember Sheldon Brown in MMC, right? I've seen that.
I think he has already mentioned it. There is an error approximation of 0.05% in the calculation, because if they have just followed 3 people, 3 different directions, and hence you can just follow which you are accustomed to it, because not much of major variations.
Yes, sir.
And that is the reason why even when it went to FDA for this final approval, they accepted these marginal changes because it has been fixed. And they did it only for the unilateral, but not for the bilateral still. It is just in the, because of this particular point. Bilaterality, when you want to do the surgery, it has to be, now FDA has to clear it. It is still with the FDA to clear it because of this particular point. The discussion was made in the two people who have done it is of course in the Eastern Rail, and there are about 4,000 patients, Americans. One of my nephew is there very much doing this particular aspect in US.
Wow.
He's trained with Tyagarajan Subramaniam, and then he has come over. And the maximum number of done is in Nebraska.
Nebraska.
That's the maximum number of cases done. So this calculation, it's beautifully done by you. I think you have taken all the three criteria. That is very good. I think that is going to pave the way for a greater success in your surgery. I think that is the area. Because complications of any this sort of surgery are three. One is speech, the second is involuntary movements, and third is already you have mentioned it as weakness. So these are the things that comes in the surgery after that. And it persists for about only 4% finally persists. 96% they get over it and they come when they compare it with the deep brain stimulation. So answering to the primary point, I think they have done a lovely way of just taking all the three measurements, and then now we have beautifully seen what is being done. It's a sure sign of success. Perseveration, poise, precision, and always gives you power.
Thank you, sir. Thank you very much.
Really enjoyed that point making. The other thing I had a doubt is that in case you have anatomical abnormality, Arul, I'm still discussing with you. Now, in case you have an anatomical abnormality in the first scan, MRI, how will you choose the point?
I mean, when you say anatomical abnormality,
I'm talking about the right and left differentiation of anatomy.
Yes, yes.
Because the majority of the time we are okay.
Yeah, we choose only one side. Right. That's why SAR said that the bilateral is not been yet approved by the FDA and also by Government of India. We choose only one side. We calculate, do the targets, at least 4 targets, and then choose the best one. Okay. The target by the atlas gives 1, and then by manually method we calculate another 3, then choose the best one.
Okay. Thanks.
Thank you, sir. Professor Mahendra Datta, sir.
It's a very good modern tool for the modern treatment.
Thank you, sir.
What are the side effects, sir?
Side effects, we do have in weakness. That's the maximum side effects we see that.
Source travels in a track.
Yes.
To the target.
The edema dissipates and then travels into the track. Okay. So invariably we give steroids, dexamethasone, 8 milligram or 4 milligram for about 3 or 4 days, and then taper it for another 1 week and then stop it. Majority of our patients did improve very well without any weakness. There is no residual weakness at all in our patients.
How many sittings you do, sir? One sitting they get it well up, or you are asking for another sitting for total recovery, sir?
No. We've done so far only one sitting.
One sitting. So maybe the time will tell you the fact.
Yes. Yeah. But the longest follow-up, as SAR said, from Nebraska, 6 years. Okay. They have done tremor patients only about less than 5%. They do the redo of the tremor because of the relapse of tremor.
You continue Parkinson drugs or you discontinue the drugs?
We reduce the drug. We not stopped it.
To 50% or 20%? Oh. How do you calculate the dose?
To be precise, we could not exactly answer that question because each day the patient has got some complications. We come focusing only on tremor and rigidity, and that part comes down. But the bradykinase does not improve that much as we expected. So the drug component could not be completely withdrawn, but about 50 to 60% the drug has been reduced.
Sir, you reduce the dose or you reduce the number of items?
Overall, the frequency, number of items.
Continue all dosage. 3 drugs or 2 drugs or 4 drugs?
Yeah.
But you reduce the dosage?
We reduce the dose. Gradually we take it up one by one. Obviously, if the tremor is gone, we don't need a beta blocker or trihexyphenidyl pacitine. We can right away stop them. But Syndopa will be continued. Because we have not treated all the 3 components. We treated only the tremor, and the remaining bradykinase and rigidity is going to be there.
How about cognitive function?
Cognitive, we did not see any cognitive side effects. The cognitive function improves, that's what your question.
It improves.
We did not see that subtypes. Probably we need to look into that, but the MRgFUS has been approved in few cases of Alzheimer's dementia. It's only on research base. We don't know that the trials, where exactly the target is, whether it's a medial temporal lobe or it's where somewhere else, we don't know the target. So it's all only a trial.
So excellent thing, sir.
Thank you, sir.
Thank you. Thanks to Madheswaran for bringing us to south of India.
Okay. Vijayan, are you there?
Yes, sir. Hello. Hello.
Please take us through.
Hello.
Please take us through. What is this ray of green lights?
Hello. Yeah. Can you hear me? Yeah.
Yes, Vijayan, yes,
I
Vijayan, I can
recognize the presence of my teacher, Professor Kaira Rajan, and also we recognize Dr. Parthiban. Dr. Parthiban has been talking a lot about stereotactic surgeries. And
Yes,
sir, for a question regarding cognitive impairment, only when we target the pallidothalamic tract, do we should be very careful that we don't go anywhere near the mammillothalamic tract. We keep the target 3 to 4 millimeter away lateral to the mammillothalamic tract so that cognitive dysfunction does not occur. The second thing regarding drug dosage, all over the world the data shows that it removes the refractoriness, just like in epilepsy surgery. Here also the refractoriness is gone. The drugs act better. And after a period of 3 months, maybe we can start reducing the dosage. And they've gone up to 80% in some cases, not all cases, sir. Drugs remain the cornerstone of treatment. This is only for predominantly drug-resistant patients. And now we've we've marked the membrane folds. We saw the latex membrane. We marked the membrane folds, removed it away from the transducer, and now we have the elements. Can you focus on the screen? We have 992 elements. That's total out of 1024 transducers. We have 992 transducers ready to fire at the target. The skull area is fantastic. We got 393 centimeters square, and then we have a skull score, that is the SDR of 0.39. That's okay. We can accept that SDR of 0.39. And then we are showing the elements also. The green lines are the elements in all the three directions, in the axial view, in the coronal view, in the sagittal view. These are the number of elements and which are going to target exactly at that level where we place the targets, that is 13.7 millimeter lateral to the AC midline, 6.7 millimeter from the posterior commissure, and 2 millimeter above the ACPC plane. Now we're going to, actually Raghu is going to sonicate now, but before that he is just prescribing the power. Then because this patient has a low SDR, we're going to use an initial energy of around 4500 joules, as you can see on the screen, 450 watts, and 11 seconds he's applied it. Basically it's 450 into 11 minus 1, that gives the joules. The watts is 450, so into 11 minus 1, that is 10, we get the joules. So, and there is an extension time of about 3 seconds, which the machine itself allows. Suppose we are not able to reach the 4500 joules, we expect a temperature around 42 or 43 degrees Celsius at this level. We are going to only align the target. We are going to only align the focus to the target now. Sonicate, Raghu. So Raghu is sonicating now.
As we discussed earlier, that we are going to be on 4 phases: align phase, treatment phase, low treatment, and the high treatment. So we're just going to see the first one, the align treatment. As he already clearly said, that this is a joules, the energy has been delivered, power is 450 watts. This is rough to achieve the temperature of about 41 to 42 degrees centigrade. We'll see, he's going to sonicate now.
Hide all. Okay, sonicate. So we have performed the first sonication. Now you can see the sonication getting started on the screen. You can see it in this this part of the screen now. On the screen, just remove this. Suresh? Right. You can see it here on the screen now. Yeah. You can see the sonication. The first sonication is about to begin now at very low energy levels of 4500 joules.
Even I was thinking. I think
okay.
Vijayan sonication sathate kaano?
Varudhu sir, it's coming now. It's coming, it started now.
It's starting now.
It's just starting now. You can see the spectrum and you can see in the screen the sonication has started. There is no cavitation here. At this level, the average temperature reached already is 45, 47. We have reached 47 average temperature. The maximum temperature reached is 49.
You can see the pink color is for the internal capsule.
Yeah.
The
The
temperature
pink color is for the internal capsule where the temperature which we have marked has not exceeded 43 degrees Celsius. We can go up to 50 there. And the sonication is over now. We have delivered 4,537 joules at 435 watts. Now Raghu is zooming in to check temperature. We are reducing the temperature, reduce the temperature to 47. So you can see the red spot on the screen. Red spot on the screen, 47. Yeah. Now that is a red spot on the screen. The green spot is the target, actual target. This is where it's delivered. Now you can take the target here and place it at the center of the dot. Place it at the center of the
This is the temperature of 47 degree.
Yeah. If we are now placing it at the center of the dot to see the right left dispersion of the dot. Yes, click. And you can see that right left is 1.1 millimeter. We'll
okay, accept, reject.
Reject. Shall we move it a little bit? Yeah. We are moving this to the center and then from there half of it, so that we half of it like this laterally.
So we already reached 47 degrees Celsius.
Yes sir, but the right left, the dispersion was slightly more than a millimeter. So we're trying to correct that. So we're going to go half of that correction now. And this is 0.5. We accept that new position. And then we're going to again sonicate again. Continue. But we're going to check the parameter in a different view now. Previously we were checking axial AP, that is we were checking the right left orientation. Now we're going to go to the coronal and coronal SI. So we'll be checking again the right left disorientation orientation here. And you're going to sonicate again. Now I think we have already had 45. We won't change. We'll keep it at this level and then we'll again sonicate. As the before the sonication, before each sonication, the MRI automatically performs a movement detection scan. It performs a movement detection scan to see whether there is any movement, and if the movement is more than 0.5 millimeter, the MRI aborts the procedure, and it'll warn you. It gives you the readings here at the lower right corner of the screen. You can see the values. 0.1, 0.3 and 0.7. So if that is so, we need not worry. There is more than, yeah, now that's a second sonication again. Okay, with the same parameters, we've achieved slightly lesser temperature of 45. That is because we are sonicating at the same tissue. When you keep sonicating at the same tissue again and again, we'll achieve lesser temperatures, but we did not want to increase the temperature at this level because we're again checking the right left orientation here. Now we're going to zoom in and see. We reached 45. So you can bring down that to 45.
11,
zoom.
11, okay.
Zoom. It's automatically there. Zoom. Yeah. This is more or less, you can see this spot there. The spot, the shape of the spot is fine. The location is also fine. The location is very much perfect, almost perfect. The distance between the center of the spot hardly would be less than a millimeter. I wouldn't say it would be more than a millimeter. It would be less than a millimeter. So we'll
There is no much lateral spread, isn't it, Vijayan?
there is no much lateral spread at all here. We're very far away from the internal capsule. There is no much lateral spread at all here. And the spot location, the target, the green thing, and the thing around it, the center of the red spot is not far away dispersed in the light left orientation. So we accept this and we continue for the next sonication. For the next sonication, though we are going to...
Vijayan, I just want to interrupt.
Yes,
this
sir.
is the internal capsule, isn't it?
Yeah, that pink line is the internal capsule. We marked it previously and that has been superimposed on the live MRI now. That is internal
and the
capsule.
target is here.
Yeah, the target is far away, quite far away. It's at least 3 millimeter, 4 millimeter away from the internal capsule, and that's very safe. So now we're going to do the sagittal SI and we're going to check the AP orientation, but we're going to increase the temperature a bit. We're going to increase to, now shall we play a game? What temperature do you want, Raghu?
50 degree.
You want 50 degrees, sir?
Previously
we'll be already going to verify stage. You can go to verify.
47.
Yeah, okay, sir. We'll increase this one, sir.
Yeah. Verify. Cancel. We're going to verify. We're satisfied with that. Now we're going to do in the coronal RL so that we'll check the SI. That is the superior inferior orientation of the spot that we have created. Now you want 50 degrees, then we'll go up to 6500 joules.
We'll double, sir, actually.
Will it be very high?
No, it won't be very high, sir. In fact, Raghu wants a little more.
8,000.
Raghu wants 8,000 joules.
No, 7,500. We don't want.
Okay, 7,500 is what you want. So we fixed it at 7,500. So 7,650 joules, 10 seconds, and
we'll see the clinical response on
850 watts. Yeah, we're going to sonicate now. We have not checked AP.
Basically, we are doing several sonications, sub-sonications, before we decide which temperature is going to act upon to give a final sonication.
Shall we check so we'll go back? It's fine, we'll leave it.
Okay.
Sagittal. AP, yeah.
Okay.
Yeah,
Then
yes.
Sonicate.
Sonicate. RL, so we'll check AP, yeah. Yeah. We're going to check the anteroposterior orientation of the spot now, but we are already in the verifying stage. So I think we will reach a temperature around 48, if I'm not wrong, 48 to 50, maybe 48.
Okay, that should be okay.
We're waiting for the movement detection scan. It's automatically performing the movement detection scan now, and then it's starting the sonication.
When the sonication proceeds, we need to lose the temperature of the water also. Here it's only
about... the temperature of the water, you can see there, it's only 15 degrees.
15 degree, yes.
And the dissolved oxygen is less than 1.
If the temperature goes high, the sonication will not be delivered.
Yes. Started, the sonication started. This is the third sonication.
Yes, sir.
The third sonication. We are still verifying. We reached 48. 49.
Yes.
We both won it, sir.
49.
You said 50, I said 48. We have reached 49.
Oh.
We've reached 49. I think we got to go in and check the clinical response also now.
Yes,
but before that, we'll also check the orientation in the AP view.
Right. Raghu, when you see the
Actually,
patient, could you
actually,
please explain to us what the improvement you have seen?
Sure, sir.
No, sir. Yeah, we'll be telling you, sir. But let's first check the spot location, size, shape. This is an AP. எதுல வச்சிருக்கீங்க Raghu? Axial.
11.
இல்ல coronal வச்சிருக்கீங்க. You kept it.
அதே தான் வந்திருக்கு.
Again, the shape is acceptable. There's
The
no
shape
much
is
lateral
acceptable.
spread.
Yeah. Go to sagittal. Click. Sagittal. Sorry, axial. Go to axial. Axial.
இந்தாங்க சார் டச் பண்ணுவோம்.
டச் பண்ணுங்க. Okay, this one.
இல்லைங்க சார் in that 11 seconds we should see sir. அந்த பேக்ல பார்க்கும்போது
மூவ் பண்ணுங்க. இது மூவ் பண்ணுங்க. Keep moving this.
இல்லைங்க சார். Zoom out.
Yeah, you got 48 there.
இது மாற்ற வேண்டாங்க சார்.
Yeah, thermal, yeah. Yeah.
இதுல வந்து 11
okay, thermal, yeah. Correct. AP. This way, isn't it?
Is that a spillover?
No, sir, not much, because that's the target, the center of the target. You can take this to the center of the target. Click பண்ணுங்க. Take it to the center of the here, center of the red spot. And you can click it there. You can click. Yeah.
Point.
The difference, as you can see in the AP, is just 0.3 millimeter from the target. So 0.3 millimeter, we'll accept it, we'll reject this, and we'll continue. Before that, we're going to check the patient now, because we've already reached a temperature of 49 degrees, and we have done 3 sonications at this target. So we're going to go inside and check the patient now. Now, camera to patient.
We could see an early improvement even in early phases of sonications. That's why we're going to see the clinical response. Anand, அந்த MRI camera. So you could see that tremor has come down markedly. There could be at least 30 to 40% improvement in the tremor already. He's checking for bradykinesia there. Still there is a tremor. Vijayan?
Hello.
Okay. Vijayan, can you tell us what did you find?
We found about maybe a 25% improvement.
Right.
We've
We
not
also
yet
felt
treated him. We are still in the verifying stage.
Right,
And he
we
does not have
identified-
any complications. His power is normal. His sensations are normal. He does not have any burning in the lips, burning in the tongue, numbness on one side of the. He does not have any. So we have not come posteriorly also. That is, we have not impinged on the sensory thalamus. We are still in the motor thalamus. We see that his hand was previously vigorously shaking, even in the resting position especially. Even without any command. Now is improvement, I would say, rated at 25%. Now we'll go to treat low. We're going to treat low.
Yes.
And shall we check coronal?
One of the
For
earliest
the SI?
signs of
Yeah.
internal capsular involvement is paresthesias and numbness. So if the patient doesn't
Coronal-
complain, then we can
coronal
confidently go further.
Now, we've changed the parameters. We're going to increase the energy now. And maybe we were at how much joules were delivered previously?
7,000.
7,600 joules were delivered. Now we want to increase the temperature to around 52 to 53 degrees Celsius.
Okay, we are aiming for 52 to 53.
Yeah, 52, 53, and we're going to check the orientation in the coronal plane, RL, so that we will be checking the superior inferior dispersion of the spot also.
Okay.
So we're going to go to treat low at this stage. We're starting, we'll be very much satisfied with the shape and position of the spot. So we're going to apply, we're going to increase, not more than that, less. Increase this. Increase it a little more. Raghu?
Yes, sir, 15 seconds.
Go to 15 seconds.
12,000.
And we'll reach about 12,500 joules. And I would expect a temperature of around 52, 52, somewhere at that level. We applied, we're going to sonicate.
This is the fourth sonication, isn't it?
Yes, sir, fourth sonication.
Okay.
We are aiming for something around 50 to 52. While the movement detection scan is on, I would like to tell that one more thing, the decision that target selection, though we have so many methods, what the chairman says repeatedly is the patient selects the target. That is his famous words, the patient selects the target. Actually, it is a patient who selects the target here. Based upon his response, based upon his side effect, he actually guides us to the target. Rather than the fancy numbers which we show here or the MRIs which we show, it's actually the patient who guides us to the target.
That's correct. The response decided by the patient, the clinical response is the main indicator to choose the target. Isn't it correct, Vijayan?
Yes, sir. Patient has pressed the stop sonication button. We'll go inside, verify why he pressed the stop sonication button.
The patient will be given a stop sonication button in his hands. If some untoward things happening to him, he can stop and press it on the way. So he must have felt some warmth, he must have felt some pins and needles. That's why he pressed the button. We'll go and ask him.
Meanwhile, as Raghu has gone in to ask the patient why he pressed the stop sonication button, we have already delivered 10,300 joules at 872 watts, and we've reached a temperature of 50 degrees, and we are checking the superior inferior orientation of the spot, and you can see the center of the spot, red spot is somewhere here, and the superior inferior orientation is not. We can reject this because this is hardly any difference. If you want, we can measure that difference. Check it again. Reject, yeah. It's only 0.6 millimeter. So we accept this. And we are going to continue sonication at this level. The spot shape, location and is all fine. The orientation in the superior inferior plane, the anteroposterior plane and the right lateral directions, all the three directions is we are satisfied. We're going to increase the temperature now. Now, Raghu,
actually he felt the heat over the scalp area.
He felt some warmth over the skull. That's why he pressed the stop sonication button. Raghu has reassured him. He's come back. He's come back here. Now, Raghu, what temperature do you want?
I think we will achieve.
Vijayan, it's cooling now. It's going to
yes, sir. It's cooling now.
100 seconds more.
We have a 100 seconds cooling time.
The water has become warm, so the no sonication can be delivered. This is the cooling time. The water is recirculating again to go to the temperature of 16 degrees.
But it's already yeah. We can continue. Meanwhile, we can prescribe the parameters. Okay. Go to 16,000 joules.
How many joules?
Not watts, 900.
900 watts.
950, no, 900 watts. Increase the time. 20 seconds. 20 seconds more now. We go to 17,000 joules. So we are planning to give 17,000 joules now. And maybe we'll increase the temperature by 2 degrees.
2 degrees, yes.
We'll reach about 52, I believe. I think we'll be on the safer side. Actually, we can go up to 24,000 joules at this level, but we don't want to do that. We prescribed 900 watts of power, 20 seconds duration, because he's already pressed the stop sonication button once. So we'll deliver 17,000 joules at this level. Apply.
19 seconds.
The cooling, we got to wait for again 18 seconds for the cooling time.
Yes, sir. Ready.
There we are. We can sonicate again.
Yes.
And should we change the orientation?
I think
we'll change the orientation. We'll change the orientation. Yes. We'll change to axial AP again.
We'll check the RL.
Yeah, we'll check the RL now. We'll again sonicate. And I think we'll achieve a temperature of around 52 degrees now. Again, we are in the treat low stage only. This is the 6th sonication.
6, sir.
Yeah.
6. Treated 4. Remaining.
5th sonication.
5th one.
Yeah.
5th sonication.
This is the 5th sonication. We're planning to deliver 7,100 joules, 900 watts, 20 seconds.
How much the target temperature are we aiming?
52, sir.
52.
The movement detection scan has been updated and you can see the numbers there, 0.1, 0.3, 0.8. So there is no movement there, no much movement, and the system is getting ready to deliver the next sonication. Again, he pressed the stop. He's pressed the stop sonication button again. So that what we'll do is next time we'll reduce the power and then we've reached 50 again. Again, we'll have to repeat this.
Yes.
We'll go and ask the patient again why he pressed the stop sonication button.
Probably he was feeling the warmth again.
Yeah, maybe he's feeling the warmth again. But meanwhile, we'll be checking the position of the in the right, left. The dispersion is not much, sir. You can see now 2 targets now. You can see 2 red dots here. And,
a lighter color and a darker color.
Yeah.
What does it mean, Vijay?
It shows the accumulated dose, sir.
Cumulative dose.
Yeah, cumulative dose, but it's not still very high. We've not delivered much cumulative dose, but again we'll accept this slight left change. There's not much again. You can check the temperature. We can move this and check the temperature. This one. Yeah. Yeah. Now we can move this yellow cross and check the temperature and the various voxels around. I can move it anywhere in the field. And the internal capsule, the boundary of the internal capsule, actually we marked it a little more liberally. At the boundary of the internal capsule, it's still 44 degrees Celsius. And here, the maximum temperature we've reached is somewhere around 53, 52.9. Though it says the average temperature delivered is 50. The maximum temperature we've even reached 53.5, somewhere very close to the target. So almost we've reached Is temperature? Tremor? There is no tremor at all. Yeah, please check. No tremor. Somebody can focus on the patient. The camera, focus on the patient, please.
Okay.
The tremor
We
is.
still have a cooling time of 2 minutes now, roughly.
The tremor is already gone. It's there, but it's about 50% better now already. The tremor is 50% better. The tremor is 50% better there. I hope you can see it on the screen. It's 50% better already. So we'll be moving the target again and we'll be sonicating again. Now we'll go to treat high in the next stage. We'll come out, we'll reduce the power and increase the duration so that he doesn't feel the vomit much. We'll go continue and we'll check the next one. Sagittal SIRP. Huh?
Target okay.
Yeah, fine. And we'll reduce to 850, but we'll increase the duration. We are actually increasing the duration and to 30 seconds, and we're going to go up to 25,000 joules now.
Okay. Probably this may create a lesion, I think so.
Yes, sir. Maybe. We'll be able to. Hope so. We'll be able to achieve at least 53, 54 now. I'm not very sure.
Right.
We'll apply and then we'll sonicate.
Okay.
We're going to sonicate again. Yes, ready?
Yes, sir.
Vijay, while you are sonicating, since he felt 2 times warmth.
That's why we reduce the power, sir. Reduce the watts.
So reduce the watts from 752?
From 900, we reduced it to 848. We've reduced it to 848. We kept the duration at 30 seconds now. And we expect to deliver 24,000 joules.
Right.
Roughly 24 to 25,000 joules. Yeah.
You have increased the duration, reduced the power.
Yeah, we reduced the power because he's feeling the warmth there. We can try this technique also. We can reduce the power further. If he stops it again, we can reduce the power further and increase the duration.
Okay.
Once more movement detection scans are being done. It's a very painstaking process. It takes a lot of time. It takes a lot of effort from the whole team. The whole team has to be awake, vigilant. We tend to doze off. I remember When we first were in Japan, I was dozing off again and again, and chairman was waking me up. He was pinching me, asking me to stay awake.
Right, we are sonicating again.
We've reached 54 degrees already. We've reached 55.
56.
This time we've almost treated. We've reached 56 degrees.
Right.
Sonication, and we've delivered the targeted. We've delivered 25,000 joules, and we've reached a temperature of 56 degrees. I thought we would reach somewhere at 54, but we've reached 56 already. We've gone to the treats high stage already, and now we will see the spot.
56.
More importantly, he did not press the button.
Yeah, he did not press because we reduced the power this time.
Right.
And sir, you would have noticed while sonicating, I was keeping my hand over here.
To stop. We can also stop the sonication process if necessary. You can see the spot again. We're checking the sagittal SI, that is the AP, and you can see there is no much smear in the AP also. There is no much smear in the AP also. We are satisfied with this. We'll go to check his clinical response now. Raghu is going in to check the clinical response again. Kevin.
On the MR camera, please. Okay.
We're satisfied. What is this? But why is it smeared like this? This is the shape, isn't it?
You can see that hardly any tremor.
Okay, fine. Wow, the tremor is gone now, completely gone. Tremor is completely gone. We'll do one more sonication at this level and then we'll check the intraoperative scan. Check the scan. The tremor is totally gone. Raghu, ask him to
spread the fingers.
Spread the fingers.
Ask Raghu to see any weakness.
Raghu, check for weakness, Raghu.
Hand grip, please.
Raghu, hand grip. Raghu, hand grip. Check the hand
that's
grip.
Excellent. No tremor at all.
Hand grip. Leg. Leg also. Leg also. Check the foot. Leg. Sensations. Sensations. இது எப்படி இருக்கு? Ask him to do this again and again.
Right.
Wow.
That's also a lot of improvement. Yeah.
That's a very good improvement. Sir, there is a very good improvement.
Yes,
Both, even that minimal rigidity is gone.
Right.
There is a cooling time of 472 seconds. So we have a lot of cooling time now because we delivered a lot of energy. And so we're going to do an intraoperative scan now, intra-procedural scan. Once the clinical examination is over, we're going to do an intraoperative scan now.
Right.
Yeah. We already have a
Hardly there
lesion.
is any
Yes.
tremor at all. Tremendous improvement.
And if we see the lesion, if we see a central coagulative necrosis on this scan, we'll stop at this target.
Yes, I agree.
And maybe we actually, yeah. Wow, you can see the beautiful Archimedes spiral, and he's written his name also. He's written his name completely, Ramamurthy, if you can read that.
We can see this, he is written on the left hand.
He is written with the left hand, yeah. He's written with the left hand. And there is no tremor at all. The tremor is completely gone. Not only the tremor, I think Raghu, you also noticed decrease in the rigidity? Rigidity and the alternating movements? Yeah, tell that.
Actually, he feels happy. He could be able to see that his tremors is reduced. Rigidity also has been reduced. He could be able to perform that movements very fast.
Right. Did you notice any of the sensory
No, sir. I
side
checked
effects
it.
like?
No deficits, sir. Yeah. No issues.
Right. Okay. So there are no side effects. Finger
No,
grip
sir.
is
No, sir.
good.
No
Even
side
legs
effects.
also normal, sir. No issues.
Right. Okay. Are we doing the check MRI
Yes,
now?
sir, we are going
Yeah,
to do a check
check
MRI now
MRI.
because we've done a long duration delivery. We've done it for 30 seconds, and you can see that the average temperature has remained above 50 for quite a long time. And
That's
so
correct.
we would have already performed, we would have already got a lesion there, sir.
Right.
We've already got a lesion there. And
Vijay, will you stop the sonication now here, or will you go ahead do another sonication?
I think
We'll check
once
that.
if we have a coagulative necrosis, we'll stop it here, sir.
Right. Okay.
We'll stop
So
it
the
here.
MRI will decide if there is a already lesion with the coagulation necrosis. We are
Yes,
going
sir.
to stop it
Yes, sir. Yes, sir.
because the improvement is already achieved.
Yes, yes. Do the scan. And we are in the process of performing the scan. We've still got another 300 seconds cooling. So that we're going to do the intraoperative scan. The intraoperative scan will be done for a small volume of MRI, only around the target, where we thought that we've made the lesion.
Okay. Vijay, we are going to hold you for the few seconds while I ask Professor Mahindatta.
Yes, sir. Yes, sir. Please go ahead. Please go ahead and
all the
interact
way
with the
from
audience,
Delhi
sir.
to view his opinions.
Yes, sir. Please go ahead and interact, sir.
Mike, please.
Very good evening. Thank you so much for asking me. When I was sitting here, I was writing something for my colleagues in different groups in Delhi, movement disorder group and others.
Right, sir. Thank you. That's very
What I
kind.
wrote, 14/02/2023, Tuesday, Coimbatore. Privileged to be part of CME, talk delivered by Dr. Jiu Cheng Chen from London and live workshop demonstration of application of magnetic resonance G small, guided. Guided is small. Guided focus ultrasound sonication in patients with essential tremors and tremor dominant Parkinson disease. Impressive and rewarding outcome. That's what I've written. This non-invasive technique is likely to replace deep brain stimulation in the indications approved.
Right.
Next, I've written its horizon is expanding to neuropathic pain, epilepsy. I have not yet written Alzheimer and stroke. I myself was not clear what was shown here. But one question I'd like to ask is, you have shown one spinocerebellar ataxia type 12, which is very common, particularly in North India. It's more common in Bania community or Agarwal community. How does it help in that? Because the origin is from cerebellar.
Yes.
So how does it help in SCA12?
We don't know exactly the pathophysiology mechanism, but as Professor said, the final common pathway will be coming from the thalamic outflow. We are just interrupting that and then stopping the outflow so that the tremor is improved.
Dentatorubrophthalamic.
Yes, exactly.
So has it been approved by FDA also for cerebellar tremors?
No, they are not very clear, but their approval is only for essential tremor and tremor predominant Parkinson's disease. So we interpret as intractable tremor and we achieved it. And then the last patient I've shown the video, he had a tremendous improvement.
Yeah.
He's from Delhi.
What I think these patients may also have good component of action postal tremors, though the intention is the maximum. So at least action postal tremor will be taken away, though intention tremor will look lesser in magnitude. That's my thinking.
Exactly.
Thank you.
Thank you, sir. Professor AVS, sir.
One of the anatomical postulation is frontopontocerebellar fibers while returning.
Right, sir.
And that is going to constitute the cerebellar signs and tremor signs also going with it. So that is why in cerebello-cognitive affective syndrome, CCAS, they have described the tremor and as well as incoordination, which is. So that is why it is improving even. Originally they started with thalamus, then went to VIM, then they went to now, like what they did in the basic brain stimulation. They have now come to the subthalamic body of Louis.
Right.
Now, officially 2022 March, the results have been given for the follow-up of all these patients. This is for your reference. And
MRgFUS.
completely MRG patients, 4 years follow-up study. And they have very clearly stated it is 54% in essential tremor group and then the Parkinson disease. And the second one is postural tremor, about 60%, and another one 70%. They have just stated that. So watch it. And you have rightly shown this, I think is fantastic. What we studied in textbook, you have seen it today with your own eyes, that how the tremor stops. I think it is a very good one. You have proved academically and as well as physiologically and anatomically. This is beautifully done work in India for the first time. I think it deserves all, especially from all the people, that it should be written as an article coming in all the magazines, because that should be done.
We are collecting the data, we are publishing.
Yeah, and you have already crossed 16. An ideal one an ideal one is 30 degrees. 30 cases for a statistical analysis. So if you get 14 more, it will stand as answer. I think the talk was brilliant. And I always say the attitude of this particular thing and the aptitude in this particular methodology of treatment, a brevity in approach, physiological in principle, carrying out with perfection. I think all kudos to you and your team and the management, and I think I sincerely feel I am elated that we are able to do it to the world. Proceed with it, and our results may not really match 53, it may even go 70%. You have shown beautifully how such a big tremor disappeared like a morning mist. Another thing is, in DBS, it takes 2 to 3 weeks.
Yes, sir.
That's another important point. As they are doing it, you are able to prove the disappearance of the, and after all, if it is going to get delayed by the point that the most of the stimulations and then the heat temperature, they are now coming to a discussion whether you should go from 45 to 55 or the discussion is taking place. I think it is left to the individual to take the decision, because you can see what's happening in the brain.
Right.
And you can demonstrate especially the necrosis. This necrosis and the surgical necrosis are almost the same. It has been necrosed means it's necrosed. So we have to follow up that patient, and some of them have developed continuous head movements like this. One such patient who had it, he developed immediately the head movements, this dyskinesia, dysarthria, and then incoordination. That's a very rare. That persisted only for 4 to 5 patients.
Right.
Rest of them had a lovely results. I think hats off.
Thank you, sir.
For intelligence, industry, intuition, and as well as perfection. Thank you.
Thank you, sir.
Absolutely. Big congratulations to the chairman, sir, yourself and Raghu. I have received number of inquiries about this from North India and Delhi, and I am sure there will be flow of cases, and soon we'll have 30 mark reaching without much difficulty.
Thank you, sir. Thanks for your blessing. Thanks for encouragement words. Yeah. Okay. Yes. Ujayan, are you there?
Yes, sir. We are ready now. We are ready for
Ujayan,
the.
Did you hear Professor ABS and Professor Mahendra Datta's
yes,
comments?
Sir. Vasishthar Vayal Brahmarishi. Thank you. What can I say, sir? I don't have words. When Professor AVS congratulates somebody, that's something really great. Now we'll go for the, you can see on your screen, please focus this. Okay. You can see on your screen 2 dots now, one a blue dot, one a dark blue and a light blue. The dark blue is the cumulated dose there in all these sonications, and it is what we call in CEM, it's 240 CEM. That's, we produced a very good lesion around the target, exactly around the target. So you can go to the next screen, and you can see that we've already produced a lesion there, but it does not show a central coagulative necrosis. So we see a white spot on T2, intraoperative T2 image. We see a white spot, and you can imagine, stretch your imagination, you can see a small dark spot, and we'll sonicate again at this. We are ready for the second sonication, probably the final sonication, and maybe we're going to keep the same temperature. We're not going to increase the temperature, we'll increase the duration to 35 seconds. Duration 35, 35,
20,
and then sonicate. Apply. And sonicate. And probably this would be the final last sonication. The movement detection scan is again automatically running. You can see the temperature is 18 degrees. The dissolved oxygen is 0.8. When the scan is running, the water will not circulate. The water doesn't circulate. It automatically cuts off the circulation.
Yes, sir.
Yes.
Vijay, we are really looking for a central coagulative necrosis.
Yes, sir. Yes, sir.
Not just a T2 image.
Yes, sir. Yes, I think we will achieve it this time. With this sonication, probably this is going to be the last one. If we don't achieve that, we'll move the target slightly laterally and again fire one more salvo.
Okay. Vijay, can I ask a question?
Sir.
Okay. The central coagulative necrosis is going to be his rest of his life?
Okay. The central coagulative necrosis, yes, usually will be there for the rest of his life. But if you do a scan, sometimes what happens is, surprisingly at 3 months and 6 months, sometimes the lesion, initially for the 1 week, 2 days to 1 week, the lesion grows in size. And later on, the lesion starts disappearing. When we do a scan at 3 months, 6 months, we may not see the lesion at all, but if we do a high definition swan image, then you can still see that central coagulative necrosis there. That remains permanent.
35 seconds. Okay.
Vijay, in our follow-up, we did not see any tremors have reoccurred.
Yes, sir.
What do you think the literature says?
The literature says about 10%. 10% recurrence. Another thing that the literature says is, if we've achieved for 57, sir, this time 57, I think we should have produced a lesion there by now.
Right.
The central coagulative necrosis which we accepted. The literature says that, especially in tremor-dominant Parkinson, if the tremor does not recur in 4 to 6 months, then we can consider this as a cure.
Initially, if the tremor does not recur for 4 to 6 months.
This is based on both Switzerland group, both on their based on their previous radiofrequency lesioning also, and the present MRgFUS. More and more the world is tilting towards MRgFUS. That's a spot size, bit smeared, but that's okay. We're going to check him clinically there. There is no tremor at all. The tremor has gone completely. The tremor has vanished. Use the rod to exaggerate the tremor normally. The tremor has completely vanished. I think we'll be stopping with this sonication. We'll be doing another scan.
Right. That's excellent. That's excellent.
Jai Surya. I think his rigidity is also gone there. You can see him perform the rapid alternative movements.
It's quite obvious, yes. The stiffness has come down, the amplitude of the movement is much better.
Yes, sir.
The repetition is improved.
We've got a long cooling time now, 670 seconds. So during this process, as they are checking for side effects also, you can see they are checking for the side effects also.
Hand grip is normal.
Yes, yes, sir. Hand grip is normal.
Squeeze anesthetize hands.
Raghu, 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 dorsiflexion, plantar flexion. Okay, kinetic. Kevin, shall we stop with this?
I'm really quite surprised that he could able to draw well on the left hand, even though he is on right-handed.
Shall we, if we get a coagulative, shall we stop?
This is what we were talking. You don't mean that with left hand still you can manage it.
You can manage it.
Right handed. Even for normal people like us, it will be difficult.
That's correct, sir. Again, excellent. Thank you.
Muttu rigidity illalla. இப்படி ஆட்டு இல்லை நீ இப்படி ஸ்டார்ட் அவரை லூஸாக விட சொல்லிடு நோ ரிஜிடிட்டி
Right. He's smiling also. Can we ask some more opinion? Professor Banu Madam is here. Madam, what do you think about this? Mike, please.
அவ்வளோதான் முடிகிறோம் விட மாட்டேங்கிறீங்களப்பா
சரி
என்னை விட மாட்டேங்கிறீங்களப்பா
Madam, your opinion, madam. You come all the way from Chennai, ma'am. Thank you very much.
Very impressive. Very impressive, especially your first man. Very impressive. I came because I've heard about it and I've seen Dr. Vijayan present in the conferences. So I wanted to see. Very impressive.
Right. Thank you, ma'am. Thank
Very
you.
nice.
Dr. Ramakrishnan, Dr. Professor Mukundan, please share your views.
As Professor Mahendrata told, this procedure will slowly replace DBS in terms of essential tremor and tremor predominant PD, sir.
We agree.
I congratulate you and Dr. Vijayan and the team, sir, for the excellence. Thank you.
Especially for the tremor, it's very impressive. That's correct, yes.
And tremor predominant PD also good results.
Right.
Thank you, Dr. Vijayan.
Hello. Am I audible?
Yes, sir, you are.
Actually, this idea, I must thank Banu Madam for giving this idea actually. Today morning only I told Dr. Arul Selvan, actually Banu Madam told us to, and also Professor Balasubramaniam, Dr. Balasubramaniam from Kumbakonam and Dr. Kalyan Kumar from Pattukottai, both of them performed exactly like this. One was asking questions, one was answering. And this idea we got only after seeing them perform at the Professor K.S. endowment lectures recently. And so, actually, Banu Madam also insisted on doing this live, and she also told me that it should be an interactive session. Thank you, Madam, for this idea. Actually, we implemented this idea, and I told this to Dr. Arul Selvan today morning only we implemented. And hope we did not bore you much.
Thank you. It was very, very nice. I enjoyed it.
Thank
Very
you,
nice.
ma'am. Thank you.
See,
That's
it's nothing
excellent.
like seeing, no? Hearing or reading is different from seeing it firsthand. Nothing like that. Thank you. Actually, I had sent one, I had referred one patient to Dr. Vijayan. Only because of the cost, that patient did not land up. Now you said, no, you're getting some NGOs to sponsor. Maybe you can help with few more patients, if
Yes,
it's
ma'am.
possible. If possible. I understand
We
if
will
possible.
try to definitely help that, ma'am.
Hello, sir.
Thank
I
you,
am
sir.
Dr. Selvakumar, anesthetist from KG, sir.
Yes, sir.
It was a nice, excellent presentation, sir. It's a good teamwork.
Thank you.
Yes, sir. It was looking like almost launching a satellite into space. Whatever you have shown me, the whole team is looking like ISRO scientists. Thank you.
Thank you. Thanks for your kind words. Is the scan still going on, sir?
Yes, sir. We got 1 more minute to go.
Right. Dr. Ramakrishnan, please, sir, share some of your thoughts.
Yes, sir. It's like a game changer. Probably it has put Coimbatore in the probably national or international map, thanks to you, Vijayan sir, and the entire team. And as Selvakumar sir said, it is like watching like an English movie like that. It's really impressive, and the results are very impressive. You see, you yourself feel elated. Thank you, sir.
Dr. Ganeshan, sir. Mic.
I was doing DBS when Arulselvam was with us. So now I see the results for this movement disorders also. So I feel for Parkinson's with tremor, I think this is the best one rather than the DBS. So I'm really impressed.
Thank you, sir. Thank you very much.
Yeah, we got
We've done 7-8 cases together.
Yeah. 18 cases we have done, no?
18 cases.
Yeah.
Can adjust the contrast, I think we'll see.
Can I ask non-neurologists, anyone who was interested? Dr. Chokalingam, sir? Mic.
Yeah.
In what way we should improve to be more successful, sir?
Yeah, I got it. So we stop.
Is there a case selection like unilateral or bilateral?
We've been licensed to do only unilateral so far, but hope, as Professor Avia said, the March results might come out. The government may permit to do bilateral cases also.
How early you can do on the second, on the opposite side?
Sir, I didn't get it.
How early you can do the opposite side?
Oh, yeah, probably we wait for 6 months.
In 6 months.
Previously, it was told that we have to wait for 9 months. They've come down to 6 months now. They've come down to 6 months. The FDA has approved 9 months now. FDA has approved 9 months. But most of the papers have now, as sir told, has come down to 6 months.
6 months now.
Even 6 months. But the FDA has approved 9 months.
That's almost a curative. Excellent.
We've got the lesion now, sir. This was the previous one. This was the previous one where we showed only the T2 hyperintensity, and this is the now the after the last sonication. You can see the central coagulative necrosis here.
Yeah.
And you can see the surrounding edema. We've decided to stop here because the patient has got a very good, excellent clinical response. We are not moving to the other targets now. We're going to stop here. This is edema. This lesion will grow in another 48 hours to maximum in about a week's time. It will keep growing. So we've decided to stop here, and we're going to end this live demonstration now, and we'll join you at the dinner at the La Meridian. And a special thanks to Professor Vasudevan for having given this excellent patient to us to help us to demonstrate this. And as always, a special thanks go to Chairman. Wherever I go, they keep asking me, how did you convince your administration to buy this one? I said, required no convincing, because he called me one day and asked me, I'm going to sign. Uh, he said, what are you, what is your thing? As usual, I was dilly-dallying, like a physician as always. We keep on thinking. Then he just said, I have decided, and he put the phone down and he ordered for the machine. Thanks to the chairman, thanks to the entire team, and thanks to the entire wonderful audience, and thanks to all our teachers and all our friends out there. Let's enjoy the dinner now. Thank you.
Before conclude, I sincerely thank all my teachers who come all the way from Chennai, Delhi, and also all my friends who come all over the places. Thank you very much for the constant encouragement. Without your help, blessings, and support, we could not have achieved this level at all. Thank you very much. So we'll do the conclusion and then we'll go for dinner, please.
I thank all the doctors who performed the live case demonstration and to show us the miracle in the world of neurology and neurosurgery where there was no blood in life. I thank everyone to be here in this evening and to experience this demonstration. Please have your dinner and travel home safe. Good night. Thank you.
அதெல்லாம் பார்த்து ரிப்பன் கட் பண்றது இதெல்லாம் காலுக்கு போகுது அவ்வளவுதானே